It's always an honor and a pleasure to introduce the Nantz National Alzheimer's Symposium each year. This is our 11th year, and we're grateful to Dr. Mazdu for assembling another stellar cast of people who have made some differences in AD. And specifically this year, we're going to be talking about biomarkers and therapy as well. But biomarkers are extremely important because they give us an opportunity to assess how patients are doing before we really even understand the status of the clinical improvement. And they're extremely important because they're opportunities for intervening early for therapy. So welcome all to this mixed media. Some of you are here in person, most are here by Zoom calls, but we have an opportunity for our colleagues and friends in Europe to be joining us, both as speakers and as members of the audience, as well as in the United States and here in Houston. So welcome all of you to the 11th Annual Alzheimer's Symposium. And we're going to lead off, as we do each year, with a message from Jim Nantz, who was a wonderful, fabulous human being who in fact started the Nantz National Alzheimer's Center, and we're very grateful to you, Jim. So let's hear from Jim. Thank you.
Hello, friends. It's Jim Nantz. I just want to welcome everyone to the 11th Annual Nantz National Alzheimer's Center Symposium. I am so excited about all of you being here, gathering, sharing ideas, exchanging new concepts, as together all of us collectively are going down that same path, trying to find ways to find a treatment and ultimately a cure. You know it's going to be an event like this that one day is going to make the difference. And I do feel like every year we get incrementally closer to having big breakthrough news. So I'm just thrilled that you've taking the time to be here. A big shout out to my heroes down there in Houston, our course co-directors, Dr. Stanley Appel, Dr. Joe Mazdu, dear friends of mine. They mean everything to me down at the NNAC. And to the speakers devoting their time and the attendees who have come from all over the planet to be here in Houston. I just want you all to know you all are an inspiration to me and to many others who are leaning on each and every one of you to come back with new ideas, new concepts. It's going to happen. Good things are going to happen. And thank you for taking the time to be a part of this. Wish I could be there. I'll be there in spirit. But please know, nothing but respect from my heart for each and every one of you. God bless you all.
Thank you very much, Jim. And thank you, Dr. Appel, for having started the Nantz National Alzheimer's Center with Jim Nantz. This is the 11th symposium, and we are delighted to have all of you either speaking or participating in this meeting. Let me go over a few housekeeping items first. So we gratefully acknowledge the support from Avanir Pharmaceuticals. Questions for the speakers, please submit them in the chat box in the live stream page. You will have a chat box there, submitted through that box. You may also submit questions at any time during the presentations. You don't have to wait for the end. And regarding CME information and disclosures, this information can be reviewed within the description area of the live stream page. You can expect to receive an email from Houston Methodist CME within 2 to 3 business days to complete a survey which will prompt you to receive your certification. So please, when you receive this email, answer it, and you will receive a certificate for participation in this meeting. We will have 3 breaks, and I'll go over the schedule now. So the morning session is dedicated to plasma biomarkers. You know, the holy grail of Alzheimer's is being able to detect the changes before there is any clinical manifestation. It's becoming clearer and clearer as we move on with therapeutic trials that the earlier we move, the better the outcome is. And of course, perhaps the ideal time to provide our patients with therapies is because before they begin to lose brain cells. And that is the pre-symptomatic stage, and that stage can only be determined through biomarkers. So the problem with biomarkers has been that they are extremely cumbersome and expensive. Lumbar puncture is not a very pleasant thing to have, and is cumbersome. PET, which has been able to show us amyloid before there is any clinical manifestation, is expensive, and again, a procedure that involves a certain time and cost. All right, so that's why plasma biomarkers are so interesting. And I think we are getting, if not there already, we are getting very close to having biomarkers, plasma biomarkers that are reliable and that would allow us to screen large segments of the population for pre-symptomatic changes. So this is a huge development, and improvements in immunoassay technology, single molecule arrays, and so on, are allowing researchers now to have these techniques at a point where they can be applied in the clinic and in clinical trials. And we are going to be hearing about this in the morning. So the first talk will be the 40 use of a high precision plasma assay in research clinical trials and the clinic by Dr. Susanne Schindler. This will be followed at 9:30 by a discussion on tau biomarkers in plasma. There will be a break at 10:20, and then at 10:30, neurofilament light will be discussed by Dr. Nicholas Ashton, and at 11:20, plasma biomarkers in the clinic and clinical trials will be the topic of a discussion by Professor Charlotte Tunisen. This is the morning session. We then change gears quite a bit, and in the afternoon session, we're going to be speaking about new therapies. So last June, we had the announcement that the FDA had approved the first drug for Alzheimer in almost 20 years. There was quite a bit of controversy about the approval, and continues as we speak. However, this is a huge development, and this will be addressed with other developments in therapy in the afternoon session. So at 1:30, Dr. Randall Bateman will be addressing a number of studies that have been done with immunotherapy for amyloid, with gantenerumab and solanezumab, in a very interesting cohort, the dominantly inherited Alzheimer's disease cohort. These are people who have a mutation that makes the disease occur in a necessary way, so one can see whether the treatment makes any difference, even in the pre-symptomatic stages. This will be followed at 2:15 by a discussion on aducanumab, donanemab, and lecanemab by Dr. Stephen Salloway. There will be a break at 3:15. I'll be speaking about neuroinflammation imaging, and then Dr. Alireza Faridar will be addressing therapy targeting adaptive immunity in Alzheimer's. So we have a full day, but I think a very interesting day, informative day, and I welcome you all to the meeting. So without further ado, we are going to move on to the first talk, use of a high precision plasma AB42 AB40 assay in research clinical trials and the clinic. And it is my pleasure to introduce Dr. Suzanne Schindler. She's an associate professor of neurology at Washington University School of Medicine. Thank you very much, Suzanne, for being with us this morning.
Thank you so much for the introduction, Dr. Mezdu, and I appreciate the invitation to talk with you all today. This looks like a great lineup. I think you'll learn a lot today from all of these speakers. To start with let me just share my screen here. If it will let me. Here we go. All right. So in terms of my disclosures, the major thing to disclose is that plasma A-beta 42 to 40 data were provided to Washington University by C2N Diagnostics at no cost. No financial incentives or additional research funding have been provided to Washington University or Dr. Schindler, but I'm going to talk about my analyses on this data that I have performed today. I have not received any compensation of any kind from C2N Diagnostics or any other diagnostics companies or for-profit organizations. So I'm going to start by talking about plasma A-beta 42 to 40 as a biomarker of brain amyloidosis. As you will hear about today, there are multiple very promising biomarkers of Alzheimer's disease, but I'm really going to focus almost exclusively on plasma A-beta, and I will leave it to Drs. Palmquist, Ashton, and Chinnison to talk about p-tau and NFL. I'll talk about first plasma A-beta 42 to 40 as a biomarker, but then using it in different settings. So in a research setting to better understand the biology of Alzheimer's disease, in clinical trials to screen potential participants and to monitor the effects of treatment, and then in clinical dementia diagnosis. So we know that amyloid plaques by themselves are insufficient to cause cognitive impairment. There are many cognitively normal people walking around with brains full of amyloid. And while these plaques silently accumulate for many years, we think about 10 to 20 years, when individuals reach a high level of amyloid burden, they're at high risk of developing dementia. So clearly, high levels of amyloid plaques are bad and associated with dementia. So there are many causes of dementia, but Alzheimer's disease is the most common, and we think that these plaques are kind of the inciting event. They're not the only thing that happens, but they are a critical event. And if you don't have amyloid plaques in your brain, you don't have Alzheimer's, because Alzheimer's is actually defined by the neuropathology, by these plaques in the brain, as well as the tangles. So understanding how and why these plaques form is really essential to understanding and hopefully someday treating Alzheimer's disease. And we now have good assays for measuring these A-beta peptides that make up these plaques. And I think they will provide us with some new insights into the biology of Alzheimer's disease and hopefully help us to find effective treatments for the disease. Now, it's actually rather remarkable that we have useful assays for plasma A-beta. This is remarkable because researchers have actually been measuring plasma A-beta for about 20 years. And for most of that time, plasma A-beta did not look like a very promising biomarker. And there's a number of reasons why these earlier assays didn't look so good. They were not very precise. So there's a fair amount of variation in the measurements. And we also did not have a good reference standard. So now we're using amyloid PET as a reference standard versus before clinical symptoms were used, which made things a lot more complicated in the interpretation. Something that is also important is that we found that plasma A-beta 42 and 40 individually are not that rate of biomarkers, but this ratio is really important, the ratio of A beta 42 to 40. And we think this may normalize for various factors. So some pre-analytical variations, so A beta tube. We know there are prominent effects of circadian rhythm on A beta production, so it goes up and down throughout the day. But A beta 42 and 40 go up and down together. And so if you use a ratio that kind of normalizes for that effect and you get a consistent number. In general, we think that low plasma A beta 42 to 40 may reflect reduced clearance of A beta 42 from brain into the plasma, as I'll talk about shortly, and or sequestration of A beta 42 into the amyloid plaques. So the plaques are made out of A beta 42, and so when A beta 42 kind of gets sucked into the amyloid plaques, levels go down in CSF, and they also go down in plasma. So importantly, for using this as a biomarker, there's actually a small difference between amyloid positive, shown here, and amyloid negative individuals. Only about 10%, that's not much of a difference. And so what that means is you need a highly precise assay to accurately identify people, to see the difference between these two groups. And because of this difference, assays that have high variance just do not perform well. And so I think that's something that is really important for people to understand who are using plasma A beta 42s or assays or thinking about doing this, is that not all the assays are the same. And there was actually a head-to-head comparison recently of 8 different assays, and some of them performed quite well with the ROC AUC of 0.86 with amyloid status, all the way down to an ROC AUC of 0.64, which is pretty bad. And in general, most data suggests that the immunoprecipitation mass spectrometry assays perform better. So you have to be careful about what assay you're using, or it may not work so well. But if you use a high precision assay, it can and does work well. So a immunoprecipitation mass spectrometry based assay that was developed in the Bateman lab at Washington University has been shown to really perform quite well and consistently across multiple cohorts, even if the blood is processed slightly differently. So it does appear that it works. However, the small difference between positive and negative means that you need a precise assay and rigorous quality control processes. So now I'm going to talk about plasma A beta 42 to 40 in research and how I think it can help us understand the basic biology of Alzheimer's disease. So the plasma A beta 42 to 40 assay that I mentioned that was developed in Dr. Bateman's lab was commercialized by C2N Diagnostics. Currently, it's the only blood test for Alzheimer's disease that's available in the clinic. So I'm going to talk about it in that context. It is not yet FDA approved, but it has CLIA approval, and we are using it. So we sent all of our plasma samples at the 980 ERC to C2N to be run on this assay. Our data set includes 1,750 matched plasma and CSF samples, representing 1,085 individuals, so it's a large data set. The CSF, which was collected the same day, same session as the plasma, we measured levels of A beta 42, A beta 40, total tau, and p-tau using the automated Lumipulse assay. So we have that for use as a reference standard. For the analyses I'm going to show you, we used a cutoff for CSF A beta 42 to 40 is less than 0.0673 as being amyloid positive. This is highly concordant with amyloid PET status. The ROC AUC is about 0.97. So, so basically, if you use this as your cutoff, you're getting pretty much, in most cases, you're identifying people who are positive and negative the same way you would with amyloid PET. We, of course, compared how this assay performed in identifying individuals with brain amyloidosis, either as identified by CSF, that cutoff I mentioned, or by amyloid PET. And we found really quite good concordance. So for plasma A beta 42 to 40, we found a ROC AUC of 0.88. And for CSF, for amyloid PET, we found an ROC AUC of 0.84. Now, C2N also provides a measure called the amyloid probability score, and this is a modeled value that takes into account the effects of plasma A beta 42 to 40, but also the effects of ApoE proteotype, which is essentially identical to ApoE genotype, as well as age. And so by considering those factors, they get a score of likelihood of brain amyloidosis. And when you look at this score, we find that the APS has even higher concordance with CSF A beta 42 to 40 and with amyloid PET status. So overall, this assay is really performing quite well in picking out the people who have brain amyloidosis. Now, in looking at this data, it's been really interesting to think about how plasma and CSF A beta 42 to 40 and amyloid PET are correlated, but may represent somewhat different processes. So Cliff Jack and others have long said that fluid biomarkers represent a transient state, whereas amyloid PET represents a cumulative stage, the amount of amyloid plaques that have accumulated in the brain over many years. So I think this is a helpful concept just to consider. Here's some scatter plots showing the correlation of these various measures. This is CSF A beta 42 to 40 as a function of amyloid PET. This is plasma A beta 42 to 40 as a function of amyloid PET. And then this is plasma A beta 42 to 40 as a function of CSF A beta 42 to 40. So you can see that the relationship of CSF and plasma to amyloid PET looks somewhat similar, and that there's kind of this L shape. Something that's interesting, though, is with plasma, we see more of these individuals who are abnormal or positive. In this quadrant down here, we see more of these discordant cases here than we see for CSF. And I will talk more about that, why that's interesting. Now, this is a baseline analysis, but I think the longitudinal analyses are more informative in thinking about what's going on here. So these plots are a little complicated, so I will take you through them. These are plots looking at the change of CSF A beta 42 to 40 and plasma A beta 42 to 40 over time. And I'll just start by saying that if these biomarkers really represented the same process, you would expect them to look pretty similar in the way they behaved, and they really don't. They look different. So the way these plots are set up is on the x-axis is the baseline value for the biomarker in rank order. And what that allows you to do is each vertical line is one individual. So you can see all the measurements of their CSF A beta 42 to 40 from one individual over time as a function of where they were at the beginning. And this black line here is their baseline level. And so if there's values above this black line, that means that they increased. And if there are values below the baseline, that means they decreased. And the arrow is pointing at the last measurement. These dashed lines are the concordance of the value for concordance with amyloid PET status, just to give you some context. And the colors denote the color, the CSF A beta 42 to 40 level. And this plasma plot is also colored with the CSF A beta 42 to 40 level, just so you kind of can think about what's going on with the CSF here. So what you see is that over time, CSF really is not changing linearly. So something that you see early on, so people with really high CSF A beta 42 to 40, these are people that you would expect to have 0 amyloid plaques in their brain. So they have values of CSF A beta 42 to 40 that are fluctuating up and down over the time period. However, something happens here that's really interesting. So right before you get to this cutoff that's concordant with what we count as being positive. And after this point, kind of a tipping point, you don't see the levels fluctuating up and down. They're almost all going down after this point. And so something is really changing here. I suspect that this is amyloid plaque deposition, and after this point, most of the A beta 42 is essentially getting sucked into the plaques. Now, plasma A beta 42 to 40, what happens seems very different. And so what's really interesting is that in most individuals, plasma A beta 42 to 40 is declining as they get older. Even people with really high CSF A beta 42 to 40, who you wouldn't expect to have any plaques. But for some reason, even in these individuals with no plaque, it seems that their A beta 42 to 40 levels are going down. So overall, what this is suggesting is that the CSF and plasma A beta 42 to 40, while they're certainly correlated, they're showing us somewhat different things. So I think the timing of these changes in CSF and plasma are also very important. So we had previously reported that plasma actually seems to change before amyloid PET. And so that if you look at people who have a negative amyloid PET scan but a positive blood test, they are likely in the future to become PET positive. But what's really interesting is we find the same stuff. So if you initially have a negative CSF test, and we follow you over 7 years, and you initially had a positive plasma test, you are much more likely to become CSF positive in the future. So again, this is suggesting that plasma changes are very early. We can see this in this plot here. The only individuals included in this plot had a negative CSF test, so they had a initially high ratio. And what you see is that over time they're going down both in CSF and plasma. But something that's interesting is that the people who are crossing over from negative to positive in terms of their CSF status, most of them are already plasma positive. So again, this is suggesting that plasma is changing before CSF. And I think what this might be suggesting is, again, a difference in biology of what these measures are reflecting. It's possible that plasma A beta 42 is actually reflecting clearance from the brain into the plasma, and it's long been thought that the one of the initiating events of Alzheimer's was decreased clearance of A beta 42 from the brain into the plasma. And so I think that this biomarker may actually be picking that up. And the fact that we see this so early in the blood may be actually taking us back to kind of the inciting event of Alzheimer's disease, even before there's plaque deposition, back all the way to the initial decreased clearance of A beta 42 that led to plaque deposition. So this is still a hypothesis, and we need to do more work to convince ourselves that this is correct, but certainly the data are giving, I think, a compelling story for this possibility. So in addition to helping us understand the biology of Alzheimer's disease, I think that these plasma biomarkers may be incredibly helpful tools in helping us to actually find treatments that treat or prevent Alzheimer's disease. And one thing that we are very interested in doing with blood-based biomarkers is screening people for clinical trials. So we know that if you just enroll people into Alzheimer's disease clinical trials based on their clinical status, in a fair number of cases, they don't actually have Alzheimer's disease. So you really have to have biomarker confirmation to make sure that people with cognitive concerns actually have the pathology of Alzheimer's disease. And the way that we've primarily been doing this recently for clinical trials is with amyloid PET scans. The problem with amyloid PET scans, they're great tests for brain amyloidosis, but they're expensive, and they're only available at specialty centers. And often at specialty centers, there's bottlenecks. There's a lot of people competing for PET scanner time. And so what this ends up doing is really creating a bottleneck in clinical trials where you have to spend a lot of money and wait a long time to be able to fully enroll your cohort. So we and others have previously shown that if you pre-screen people with a blood test, you can pick out the people who are likely to be amyloid PET positive. And then you only have to do amyloid PET scans on a much smaller number of people. And since that amyloid PET stuff is a bottleneck, by doing that, you really reduce the time and cost of the trial. So we have been thinking a lot about this and thinking about the best time to do the blood test. Should you do the blood test right before the amyloid PET scan, or should you do it even earlier, right after the initial screening phone call, before the before the screening visit? And so we have actually made a web-based modeling tool to help us think about these sort of things. You're welcome to visit this. The point is that if you incorporate a AD blood test into your screening for an AD clinical trial, really at any step, but earlier is better, you can significantly decrease the cost and the time that it takes to enroll your cohort for the trial. And people at this large trial, the HEAD 345 trial, have already figured this out. So this is a really interesting trial where they take people who are cognitively normal, have no symptoms of Alzheimer's disease, and do an amyloid PET scan on them. And if they're positive, then they enroll them in a trial to see if they can slow or prevent the onset of Alzheimer's disease symptoms. The problem with this logistically is if you just screen people with an amyloid PET scan, the majority of them are going to be negative. Probably about 75% of people. It all kind of depends on your inclusion criteria and the age you set. But you end up doing a lot of amyloid PET scans for people who are PET negative. And so that's, again, very expensive and time consuming. So this trial realized this problem, and they, on their own, used the test from C2N Diagnostics to see whether this blood test could pick out the people that were PET positive. And what they found is that this blood test did pick out, not all, but certainly the majority of people who were amyloid PET positive, even people with very low levels of brain amyloid. And I'm just showing one result that they presented at the CTAD conference. They found that if you also considered age and ApoE genotype, that you did a little bit better. So this trial is now using the blood test. So they're screening people first with the blood test, And then they only do the amyloid PET scan on people with a positive blood test. And they expect that this is going to significantly reduce the time and cost of enrollment in their trial. So I also expect that combining blood-based biomarkers may further improve the identification of individuals at risk for cognitive decline. This is work by our group led by Andy Aschenbrenner, showing performance on a cognitive composite over 6 years as a function of baseline CSF or plasma A-beta 42 to 40 or NFL and NFL. So this is high A-beta 42 to 40, low A-beta 42 to 40, same for plasma. And then it's stratified by NFL levels, where this is a low level, which is good, or a high level, which is bad. And so basically what you see is that people with a low A-beta 42 to 40 and a high NFL, those are the people that perform the worst. And these models, we find that combining these markers together helps you really pick out the people who are likely to decline over time. So this is helpful because as you're designing your clinical trial, you want to pick out people who are likely to decline, or else you end up with a placebo group that doesn't change, and then you have difficulty seeing the effect of your treatment. So we were talking about screening individuals for clinical trials with a blood test. This is actually using these blood tests to monitor the effects of treatments. So this is data presented at AAIC last year, looking at the effects of lecanemab, an anti-amyloid antibody, on plasma A-beta 42 to 40 and amyloid PET. So this is a little complicated plot again, so I will explain it. This block right here is the treatment period, where you're either on placebo or the treatment. And then this is a gap period here, where even the people who are on treatment are taken off. So there's no treatment going on right here. And then this is the open label extension, where everybody gets treatment. So this black line is amyloid PET in the placebo group. And what you see is it's actually going up a little bit, but not that much over the course of the study until the open label extension, when it goes down. Now you can clearly see the effects of the treatment, the solid blue and green lines here. This lecanemab is clearly associated with a decrease in amyloid PET. And that's consistent with what we know about lecanemab, that it's removing amyloid plaque from the brain. So what's really neat about this data is you can see also at the same time what's happening with plasma A-beta. So this dashed line is plasma A-beta 42 to 40. So amyloid PET, they move in different directions. High amyloid PET is bad, low A-beta 42 to 40 is bad. And so what you see is that over the course of this trial, the people in the placebo group are low, which is bad, and they stay low until they get to the open label extension. But people that are taking the drug, their level is going up. So you see basically the same thing with the plasma biomarker that you saw with amyloid PET, which is great. That means that the plasma biomarker has utility in making sure that the drug is actually working and doing what it's supposed to do. But something else that's very interesting about this data is what happens in this gap period. And what happens in this gap period, and this is when the drug is stopped, is that plasma A-beta 42 to 40 relatively quickly starts becoming more abnormal. And that's a little bit different than what you see with amyloid PET. With amyloid PET, it again starts to become a little bit more abnormal, but not nearly to the same degree. And so what this is overall suggesting again is that amyloid PET and plasma are showing somewhat different things, and that changes in plasma may precede those in amyloid PET, which makes sense because we're thinking of plasma as a biomarker maybe of clearance of A-beta-42 from the brain, versus amyloid PET is really measuring kind of the cumulative number of amyloid plaques in the brain. So I would say overall what this data is showing us is that plasma biomarkers can be really valuable tools in assessing these effects of these treatments. All right, so now I'm going to talk about using blood tests, Alzheimer's disease blood tests in clinical dementia diagnosis. Of course, we're all very interested in this as clinicians. And I see patients in a memory clinic on a weekly basis. When a new patient comes in to see me, I do a comprehensive workup. I do a thorough history, and then a neurological examination. I do brain imaging and blood work for things like blood counts, blood chemistries, thyroid function studies, and vitamin B12 levels. And if I think the patient may have something that's treatable, like I suspect they might have sleep apnea, or I'm concerned that they may have depression that's causing or exacerbating their condition, then I will recommend additional interventions or testing. Something that's kind of interesting about our current practice is that while we have these really good biomarker tests for Alzheimer's disease, we don't typically use them. And so there's actually not good data out there on this, but I would expect that less than 5% of individuals presenting with possible Alzheimer's disease get biomarker testing for Alzheimer's disease. That's pretty, in some ways, shocking that we have good tests for disease and we almost never use the test in clinical practice. But there's actually good reasons for this, and there are things that I've alluded to in terms of amyloid PET being quite expensive, and also CSF biomarkers, while they're fabulous and very informative, a lot of patients do not really want to do an LP. And we really have limited capacity to do these tests. So it is quite interesting that we have these tests, but we just don't use them in clinical practice right now. Unfortunately, even though I, on all my patients, do a thorough evaluation, which sometimes takes a while to get all these tests back and put together all the information, even when we do this really comprehensive evaluation, the cause of cognitive impairment is often unclear or even incorrect. So there was a large study called the IDEA study, and they enrolled about 15,000 patients with cognitive impairment of unclear cause. And they found that when specialists, people like me, said they didn't know the diagnosis, we were often right. We didn't know the diagnosis. Individuals with a diagnosis of Alzheimer's disease as the suspected etiology, about 25% of the time it was changed to something else. And individuals where we thought it wasn't Alzheimer's disease, after the amyloid PET scan, it was changed to Alzheimer's disease in about 11% of patients. So overall, about 36% of the time, the leading diagnosis changed after the amyloid PET scan. So that's actually concerning. That means that in about 1 in 3 of these patients where we have uncertainty, our leading diagnosis is wrong. Another thing that I mentioned earlier is that if we just diagnose people based on clinical criteria, we have found in clinical trials that if we later do biomarker testing, about a quarter of the time we were wrong. That these individuals who were highly vetted and we followed for some period of time thought had Alzheimer's disease, about 25% of them, a quarter of them, did not have Alzheimer's disease. So overall, what this is suggesting is that without biomarker testing, we are often wrong in our diagnosis, maybe as much as 1 in 3 or 1 in 4 patients. So that's a lot of misdiagnosis. So when should we use biomarkers? Well, in general, I would say that we do biomarker testing right now when we think it's highly likely to affect diagnosis or management. There have been appropriate use criteria drafted for both amyloid PET and CSF biomarkers. They're actually a little old now, considering all the developments in the field. They mostly recommend that you do these biomarkers for patients presenting with atypical early onset and uncertain dementia. As Dr. Mass mentioned, there has been a drug approved now for use, and appropriate use criteria have been drafted for that drug that requires biomarker confirmation of AD prior to prescribing it. And this is a really important development. Many of us are not currently prescribing aducanumab. However, it's my expectation that in the next few years, there's going to be more and more Alzheimer's disease treatments that are approved and available. And increasingly, I think we're going to need to be doing biomarker testing on a much greater proportion of our patients to determine whether patients may be eligible for these drugs. I think something to consider as we think about how we're going to increase our capacity to do biomarker testing is the threshold for testing. So there has really been quite a high threshold for amyloid PET and CSF biomarkers. And that's, I think, really related to the significant costs, risks, and perceived risks of these biomarkers. So amyloid PET scans, at least at Washington University, cost about $6,000. They're not reimbursed by insurance. They involve radiation. They're only available at specialized centers. So this is not something that we can really routinely order. CSF biomarkers are less expensive, so they cost about $2,000 once you put in the cost of the LP and routine tests. And they are typically reimbursed by insurance. So that's what we typically use for patients, because insurance will pay for it. However, a lot of patients are not very excited about getting a spinal tap. And so there's kind of a high barrier for entry, a high threshold for doing this test when there's so many drawbacks to it. Something that's really unique about AD blood tests is that this threshold may be much lower because there's just many fewer drawbacks to their use. Patients tolerate blood collection well. The blood tests may be less expensive to perform. So those are great things. Currently, the only test that's available is not reimbursed by insurance, and it costs $1,250 out of pocket. However, there is a sliding scale. Now, that does represent a significant barrier to use, and I am hopeful that at some point, this test, and I strongly suspect that other tests will be available in the next few years. I am hopeful that insurance will start reimbursing for these so that we can use them more often, because I think we're going to need to use them if there's more drugs available. And I think that these AD blood tests may allow for much broader diagnostic testing for Alzheimer's disease. So at Washington University, we have performed the AD blood test now on about 60 patients. We've typically used it for patients who had contraindications to LP. So for example, people that were on anticoagulation or people who just really did not want to do a spinal tap. As I mentioned, the amyloid PET scan is $6,000 out of pocket, which really makes it completely inaccessible to most of our patients. So with this blood test, we have found it to be helpful. The majority of the time, it provides a pretty clear positive or negative result. And because we think this is useful, we're currently planning a study to change the way we're thinking about using AD blood tests. So the way that this would work is that patients with cognitive impairment, potentially caused by Alzheimer's disease, at their initial visit would undergo an AD blood test. And then their clinicians would get that data and use the results of that test to guide their evaluation management. Now, something that's really important to emphasize about this is that the blood test is not assumed to provide the diagnosis. Instead, it's one piece of information that's considered within the context of all the other information. The patient continues to be evaluated for all the non-AD etiologies of cognitive impairment, especially those that could be treated. And that's true even in those with a positive blood test. So it's not that we're doing the blood test, and if it's positive, we say they have AD, and if it's negative, we say they don't. So we do the full workup. And because we know the blood test isn't perfect, if we think it's indicated, we do an amyloid PET scan or CSF biomarkers. And it'll be interesting to see the concordance of those measures with the blood test. So the reason why we want to do this is that we think that this paradigm could lead to earlier and more accurate diagnosis of Alzheimer's disease. And this is going to be really important if and when we have drugs that work. Because we think these drugs are likely to be most effective when you start them early. And so if you're not diagnosing people for a year because you're going through this full workup and you don't do biomarkers till the very end, that means that you're missing a window of opportunity. But if at your first visit, you know whether someone's amyloid is positive or amyloid negative, then I think that will change the way you approach the patient. And you could start putting them down a pathway where you're thinking about treatments. Something else that's also very important to think about is to make sure that these blood tests are relevant to everyone. So almost all Alzheimer's disease biomarkers have been studied in really pretty much exclusively healthy, well-educated, non-Hispanic white individuals. And of course, that's not at all representative of what we see in our larger population, in the population that's affected by dementia. And we know that there are many variables, age, sex, ApoE genotype, comorbidities, self-identified race, that are associated with AD biomarker levels. So working with Tommy Carey, Nick Ashton, who's going to be speaking a little later, Kai Blenow, and Heinrich Zetterberg in Sweden, we recently evaluated the relationship amyloidosis in plasma A-beta 42-40, p-tau 181, p-tau 231, and NFL in a cohort that included self-identified African Americans and non-Hispanic whites. And what we found is that African Americans had a lower probability of brain amyloidosis compared to non-Hispanic whites associated with the same plasma p-tau 181 and 231 levels. However, plasma A-beta 42-40 performed consistently across racial groups. So we need larger studies to look at this in more detail and to understand why there might be differences. In this cohort, we did find differences in comorbidities. It's possible that that could be playing a role in our results. But this just adds to the body of research demonstrating that we can't just study these biomarkers in non-Hispanic whites and apply it to everyone else. We really have to study these biomarkers in diverse groups. Otherwise, we could end up disproportionately misdiagnosing groups that are underrepresented in AD research. So in conclusion, we think that highly precise plasma A-beta 42-40 assays can identify individuals with brain amyloidosis. And based on the data we have, we think the plasma A-beta 42 to 40 may represent a different process compared to amyloid PET or CSF A-beta 42 to 40. Screening with AD blood tests, whether it's plasma A-beta 42 to 40 or something else, may significantly decrease the cost and accelerate enrollment in clinical trials. Plasma A-beta 42 to 40 looks like it can be used to monitor the effects of treatments. And Alzheimer's disease blood tests, when used as one component of a dementia evaluation, may potentially improve the accuracy of dementia diagnosis. And I would like to acknowledge all the research participants who underwent spinal taps for this work and provided blood and underwent amyloid PET scans. Obviously, we couldn't have done any of this work without their participation. I'd like to thank my mentors, John Morris, Randall Bateman, who's going to be talking to you later this afternoon, Ann Fagan and David Holtzman. Other close collaborators really on all of these projects. There are quite a few people involved. These are some of the analyses that I mentioned. I'd like to especially thank Yan Lee, who's really been involved with a lot of different projects. I talked about Andy Ashrenbrenner's work on predicting cognitive decline. This was actually a large team of people involving the business school developing this application to better understand when we should do AD blood tests to accelerate enrollment in clinical trials. And then our collaborators in Sweden who provided very valuable data for us to look at racial differences in plasma biomarkers. And I'm happy to take any questions.
Thank you very much, Dr. Schindler, for an outstanding presentation. I don't know if we have any questions from the audience at this point, but I want to ask you perhaps to elaborate a bit on the mechanism by which amyloid is less clear from the brain. WashU was the place where we had a wonderful study a number of years ago showing that amyloid clearance rather than overproduction was the problem in AD. And I wonder whether there is any data that you could discuss for us in this regard.
Well, I think that, there's a number of papers, particularly by Dr. Bateman's group, some of which use stable isotope labeling to look at clearance. There's one in particular by Bruce Patterson, looking at how these different measures change, including in blood. I think we're still trying to understand all this, but clearly it appears that A-beta 42 clearance from the brain changes with age. I don't know why, but there do appear to be very strong effects of age in clearance. And I think, while we don't know why and we need to study it more, it clearly is very important, and it may be what actually leads to Alzheimer's disease. I think that when we think about Alzheimer's disease, we're thinking about it late, after people have plaques, and we're thinking about all the downstream consequences and all of this. But I think that Alzheimer's starts, maybe not just 10 or 20 years before the onset of symptoms with plaque deposition, but there may be events that happen even 30 years before people start to develop symptoms. And that's kind of a shocking to contemplate, really, that, 40 years old and I could be having right now changes in my brain that can lead to something 30 years later. It's pretty amazing.
All right, thank you. And of course, those of us who are in the HEAD study are very grateful to you for this wonderful work. We are using the plasma biomarker to screen patients, as you told us. We have questions from the audience. Perhaps you can see them. Can you see them on your screen?
Actually, no, I can't.
So
Let's see.
go ahead, please.
Yeah, hi. Very nice talk. Thank you. This is Rabab Alaham. I'm a postdoc at UTH in Houston here. So my question is, did you or are you planning to follow any of those patients for their post-mortem brain pathological assessments, or there was any also kind of relation between the amyloid PET and the plasma or CSF biomarkers?
Yes. So Alzheimer's, the gold standard for Alzheimer's is neuropathology. So it's going to be important to correlate all of these fluid biomarkers with neuropathology. That's something that we're very interested in doing in our current data set, and we have plans to do that. And in patients, it's more difficult because we don't routinely do autopsies on our clinic patients. However, I did just recently have a patient who had the blood test who passed away, and we are evaluating her brain. So, the issue is you really want to have a large sample to look at this. And so, looking at it in patients may take a while, but certainly in our research cohorts, I think that we'll be able to look at this in some detail.
Okay, online we have a few questions. Let's begin perhaps with the last one. On the Swanson 2021 presentation slide, what drug was used in this study for the Swanson?
That was so the Swanson slide that was presented at AIC, they used lecanemab. So that's a drug by Eisai. And I think that if you go back to the AIC abstracts, you can probably pull up that presentation.
Thank you. There's a question actually about plasma p-tau. Plasma p-tau is going to be discussed extensively in the next presentation, so perhaps we can skip that one. The next question is about the possibility of using similar techniques for cardiac amyloidosis. So, any comments on this?
So, in terms of amyloid, I would say that in general, we think that, so there's different types of amyloid, and some amyloid basically means that you have thioflavin T bindings, you have beta pleated sheet conformation, but in Alzheimer's disease, the amyloid is made out of A beta. So generally, we think that amyloid PET scans, the signal we're seeing is coming predominantly from A beta fibrils, not from other types of amyloid. Now, there are other types of amyloid that do affect other parts of the body, but in general, we don't think that those are having a huge contribution to amyloid PET signal or much. There's always some non-specific binding with these tracers, but I don't think that that's probably playing a major role.
Thank you very, very much. Thank you very much for your participation in the symposium, and of course you're welcome to attend the rest of it. We are going to move on with a presentation on plasma p-tau biomarkers. Our speaker this morning is Dr. Sebastian Palmqvist. He's an associate professor of neurology at Lund University in Sweden. We can have the presentation, please.
Hi, my name is Sebastian Palmqvist. I'm a neurologist working at the memory clinic of Skåne University Hospital in Sweden, seeing patients 2 days a week, and the rest of the week I work as a researcher, associate professor at Lund University in Sweden. I want to start by thanking the organizers for inviting me to this conference. Unfortunately, I won't be able to attend live, so this is a pre-recorded presentation. I'm recording this on Tuesday, just as a disclaimer in case there's a major breakthrough between Tuesday and Friday. That's why I haven't included it. And today I will talk about plasma biomarkers for tau. Here are my disclosures, and none of them are really relevant for this presentations. So in my talk, I think I will begin quite broadly, since I know this is a broad audience, and then I will slowly go into more and more details in this field. But just for those who are new to Alzheimer's disease, I want to point out the tau pathology that I will talk about today. So here on the left, you see a hypothetical model of the pathogenesis of Alzheimer's disease, starting with the accumulation of beta amyloid. And at some threshold here, beta amyloid in the brain seems to trigger or facilitate the accumulation and spread of tau, which is the pathology that causes the main symptoms in Alzheimer's disease. And then you get a neuronal damage that can be measured as atrophy, and later on cognitive symptoms that can occur early or late depending on your cognitive reserve, and finally functional deficits in your daily life. So that is sort of the overall picture of Alzheimer's disease that occurs over several decades. And I also want to briefly mention the diagnostic criteria for Alzheimer's disease, because I will connect plasma biomarkers for tau in the diagnostic criteria for Alzheimer's disease. And the diagnosis of Alzheimer's disease was for many decades characterized, or could only be established by neuropathological examination, identifying beta amyloid containing plaques and tau containing tangles. But then in the mid-80s, we got the first clinical diagnosis of Alzheimer's disease, probable Alzheimer's disease, based on symptoms, mainly memory impairment. And there was some overlap with this original definition of Alzheimer's disease, an overlap of around 70–75%. And since 2018, we have criteria for Alzheimer's disease, again defining it as a disease where you have evidence of beta amyloid and tau pathology. And we have different biomarkers that we can in vivo use to measure these pathologies. You have just heard Susanne Schindler talk about beta amyloid, and the ones that we commonly use in clinical practice is not yet plasma biomarkers to a far extent, but it's mostly CSF, cerebrospinal fluid biomarkers of beta amyloid pathology, or amyloid PET. And for tau pathology, we have cerebrospinal fluid analysis of phosphorylated tau, or p-tau, or we can also use tau PET, which is not clinically available in most countries. And finally, we can measure neurodegeneration, but that is not specific for Alzheimer's disease, but can serve more as a stage marker or somewhat increase the certainty for the diagnosis. But the summary of this, or the important take-home message, is that biomarkers are very important for an accurate diagnostic procedure of Alzheimer's disease. If we look at the diagnostic accuracy for Alzheimer's disease in primary care without any biomarkers, it's more or less like tossing a coin. And I guess it would be better to just guess Alzheimer's disease in every dementia case that you see, because the prevalence is around 60–70%. But not that high, around 70–80%. And I think this was fairly nicely shown in a very large US study using amyloid PET, where the memory clinic physician determined the clinical AD diagnosis without biomarkers, and in 72% of those cases, the individual had a normal amyloid PET, that is, did not have Alzheimer's disease. And this is not just some sort of academic interest here, but it has real clinical purpose here. And this study showed also that it changed the management of these patients in the majority of cases. And perhaps the most important point here is that when we have disease-modifying treatment, or already we have one available in the US, aducanumab, it will be a requirement in order to start the treatment that we actually verify the pathology that we will have the treatment target. And another aspect highlighting the importance of identifying the pathology is the latest clinical criteria for Alzheimer's disease. So in order to diagnose a patient with established Alzheimer's disease, you require evidence of both amyloid and tau pathology in addition to the clinical phenotype. And as you can see here, the probability decreases depending on how you verify the disease using biomarkers. And actually, according to these criteria, they find it non-accessible to determine the likelihood of Alzheimer's disease if you don't have biomarkers for amyloid or tau. But the problem we have here is the accessibility of these biomarkers. They are in many ways fairly easy, but many of them could be considered complicated. For example, doing a lumbar puncture here is me taking a photo of a medical student at our clinic doing the lumbar puncture. It's a fairly simple procedure, but it's not commonly used in many clinics. So that's why it's not so accessible. And we have amyloid PET, which is really expensive, and tau PET not yet approved for clinical use in many countries, and maybe easier to do MRIs and FDG PETs. So the problem is that we need more accessible biomarkers to identify these pathologies. And this is where I finally come to the main point of this presentation, the plasma biomarkers. And here I will focus on plasma biomarkers for the tau pathology. And I will do this by going through different studies focusing on plasma phospho-tau, or p-tau. And I want to start by mentioning something about the pathophysiology of tau or phospho-tau in Alzheimer's disease. So tau as a protein is one of the building blocks of microtubule, which is, one could say, maybe the railroad of the neurons good for transportation. But what happens in Alzheimer's disease is that there is a disintegration of the microtubules and a hyperphosphorylation of the tau proteins, and they aggregate in larger and larger structures, finally in these tau-containing tangles inside neurons. And I'm not going to go into the details of this phosphorylation process. I just want to mention here that you will see me mention different types of p-tau, p-tau 181, 217, and 231. And these refer to different phosphorylation sites at the tau protein. So looking at plasma phospho-tau, here you see it as a function of increasing amyloid burden in the brain, and that is sort of like a proxy for time in the disease. And if you compare these different plasma biomarkers, you can see that plasma p-tau starts to increase fairly early on and is the most dynamic of these different plasma biomarkers. That in these non-demented individuals included in this study, you just see that there's a gradual increase as the disease progresses. And looking at the starting point of the increase of plasma phospho-tau in the disease, it actually starts to increase before you see clear evidence of amyloid pathology in the brain, that is amyloid positivity, here using amyloid PET. So it's a fairly early marker in the disease. And this is shown in common sporadic Alzheimer's disease. You see a similar trajectory in autosomal dominant Alzheimer's disease. In the first panel here is from the Diane study, where you see the increase of p-tau 217, here approximated around 21 years before onset of cognitive symptoms. And at the bottom here, a completely different cohort, Colombian cohort, with a striking similarity in terms of where plasma phospho-tau starts to increase. Here it starts to increase about 20 years before expected onset of cognitive symptoms. So if this marker starts to increase this early in the disease process, is it really a marker of tau that I showed in the beginning, sort of happening later on in the disease process? Well, I guess the answer to that is both yes and no. There are several studies examining this. Here's one of them, where you see to the left, here we have used the neuropathological verification of beta amyloid plaques and tau-containing tangles. And in the first panel, you see that there is a significant increase with beta amyloid plaque count adjusted for tau tangle count with plasma p-tau levels. And in the next panel, you see that there's an independent association with tau tangle count adjusted for beta amyloid plaque count with plasma p-tau levels. So both of these seem to be associated with plasma p-tau levels. And the same is shown here on the right using in vivo biomarkers, amyloid PET and tau PET. And this was further illustrated in this paper, where we saw an association with between beta amyloid and phosphorylated tau only in the early disease stages, but in later disease stages, there was an association with both beta amyloid and tau. So it seems like it's a marker for both pathologies, that maybe beta amyloid plaques tends to trigger the hyperphosphorylation or the secretion of this hyperphosphorylation of p-tau. And this has also been shown in CSF in several papers. Another way of looking at this is in this study, where we examined the association between plasma p-tau levels and the tau tangle counts. And in blue, you see the tau tangle counts in those with Alzheimer's disease. And in red or brownish red, you see the association between plasma p-tau and the tau tangle count in those with tau in the brain, but it's not Alzheimer's disease. And you see that the biomarker seems very specific to Alzheimer's disease tau pathology, but it's not at all associated with tau pathology in other dementias. Moving on here to the use of plasma tau in AD diagnostics, there are several papers on this subject the last 2 years, and I'm going to show some of them. Here to the left is a paper on plasma p-tau 217 in a large study of around 500 to 600 participants. And what I want to highlight here is that you see individuals with Alzheimer's disease dementia have clearly elevated levels of plasma phospho-tau. And if you compare them to individuals with other causes of cognitive impairment, but without beta amyloid in the brain, the increase is around 700%. So quite a large median increase. And you can also see in this panel that it's not at all increased in any other neurodegenerative disease. And you can also see the stepwise increase of plasma phospho-tau with increasing disease stages. So in those that are cognitively unimpaired but have beta amyloid in brain, there's a slight increase. It increases more in those with objective cognitive impairment and has the highest increase in at the dementia stage. And the same has been shown for plasma p-tau 181. And this figure also highlights that maybe the amplitude of the increase when measuring plasma p-tau 181 is not as large as when analyzing p-tau 217, but I will go into more details about that later on. So how does plasma p-tau compare to other fairly accessible biomarkers? Well, in terms of accuracy for differentiating Alzheimer's disease from other neurodegenerative diseases, it has a very high area under the ROC curve, or here in this study of 0.96, higher for 217 than for 181, and significantly higher also compared to using MRI measures or plasma neurofilament light that Nick Ashton will talk more about. And in terms of using a single cutoff and getting sensitivity and specificity here using an a priority cutoff, it has a very high sensitivity for AD dementia and a fairly good specificity. And the reason for this not as good specificity is that many of these other non-AD disorders still can have AD pathology. And in this study, we also compared plasma p-tau to other advanced measures such as tau PET and p-tau measured in cerebrospinal fluid. And in this paper, we did not find any significant differences here. Moving on here with a comparison of different variants of plasma p-tau. I mentioned in the beginning that we have different epitopes here. I have mostly mentioned here 181 and 217, but there are also many studies on p-tau 231. And some of these studies suggest that maybe p-tau, plasma p-tau 231 is an earlier marker than plasma p-tau 181, shown here in the left panel, where you again see plasma p-tau levels as or against beta amyloid in the brain. As you can see here in this function of p-tau, function of a beta amyloid accumulation, that it seems that p-tau 231 starts to increase earlier than p-tau 181. And this is also shown in a different manner in the panel below, where you see that already in the second quartile of amyloid PET burden in the brain, there is a significant increase of p-tau 231, while this increase is not significant until the fourth quartile for p-tau 181, indicating that maybe p-tau 231 starts to increase earlier in the disease. Another recent paper also hinting at the same thing here is this one, looking only at pre-symptomatic individuals with many of them with amyloid in the brain. So this is the earliest stages of this disease, where there is a significant and higher association between p-tau 231 and amyloid PET signal in the brain for 231 compared to 181. But it's not just a matter of measuring this epitope or where the phosphorylation site is. Many other factors are important, such as the assay platform being used or the type of producer for the antibody. So, for example, in this study on the left here, you can see that the performance of p-tau 217 and p-tau 181 is very similar from two different producers. And also 231 from one of these vendors. But depending on vendor here, the performance varies quite a lot. And I think this is also shown nicely in this paper here. Also, again, highlighting that maybe it's not just the phosphorylation site, but also the platform that matters. And maybe the take-home message here is that all in all, most of these p-tau variants perform very well. And maybe it's not as important if it's 181 or 231 or 217. In the end, maybe you have to find a platform that works good and could be automated and used in clinical practice. For the final part here, I want to delve deeper into the possibility of combining different plasma biomarkers and also combining them with other accessible measures that we have in clinical practice in order to answer the question when we have an individual with memory complaints that wonders, will I develop Alzheimer's disease or not? And this is the aim we had in this study. Where we looked at consecutively recruited individuals to our memory clinic. They were non-demented and had either subjective or objective cognitive impairment. And we followed them for up to 6 years. In this main analysis, we looked at progression to Alzheimer's disease dementia within 4 years and differentiating that from progression to other dementias or being stable or even normalized in cognitive function. And we looked at different demographic measures. We looked at different plasma biomarkers, plasma p-tau, plasma NFL, plasma beta 42 to 40, looked at MRI measures and also different cognitive tests. And so like in a trade-off between model complexity and performance, we found that a combination of plasma phospho-tau, ApoE genotyping, which is a readily available analysis, a simple memory test, trying to memorize 10 different words, and 2 executive tests, trade-making test B and animal fluency, which also kind of a verbal test. We had an accuracy of around 90% of predicting whom would develop Alzheimer's disease dementia within 4 years. And we saw similar accuracies when predicting progression within 2 years or a longer progression period within 6 years. And actually, plasma p-tau worked really well. We could not improve this model when we instead use CSF plasma biomarkers, or CSF biomarkers instead of plasma biomarkers. And we also confirmed this variable selection and validated in a large North American study. And then we actually compared plasma p-tau to ourselves. That is the prediction that we as physicians had to do at baseline before seeing the biomarker results. So we had no access to the CSF results at this point, but access to an hour-long cognitive test battery, different ADL and symptom questionnaires, and also seeing the patient for at least an hour and a half, something like that, trying to guess, is this an individual that will develop Alzheimer's disease dementia or not? And it turned out that this is pretty difficult to do at the SCD or MCI stage. We had an AUC of 0.72, which was significantly worse than just using plasma phospho-tau. And when again combining plasma phospho-tau with ApoE, memory and executive function, it was a very high accuracy of 0.90 again in this subsample, or 0.89 if not including ApoE. So finally in this study, we developed a model that we cross-validated in our validation sample, the North American study, and implemented this as a tool just for research and education purposes only. But I'm just going to show you how this works. Hopefully if I can get my Safari browser to start. Okay, so I'm just gonna show you maybe some rough measure of how this could work in the future as a decision tool, where you can enter the ApoE genotype. You can enter the plasma p-tau here as a z-score, so it can be used if you have p-tau 217 or 181, doesn't matter, as long as you normalize the levels to amyloid negative controls. As you can see, if you have a normal p-tau result and perform well on cognitive tests here, you have a very low risk of progressing to Alzheimer's disease. It's also possible that you have a fairly odd result here with clearly pathological plasma results, a very high p-tau result, but perform well on cognitive testing. In this case, you probably have Alzheimer's disease in the brain, but it's very difficult for this algorithm to predict whether you will progress to AD dementia within 4 years, or if you will stay stable for a longer time period. And in case you have clear evidence of AD pathology and also performs poorly on cognitive tests, then in this case, you have a very high likelihood of progressing to AD dementia. So going back to the presentation here, I just want to briefly mention how we are now trying to validate such an approach in primary care in a large new multi-center study, the BioFinder Primary Care Study, where we include 800 participants from 25 primary care units. We try out standard pen and paper tests, new digital tests, speech recordings, and so on, and also different plasma biomarkers, using a specialized memory clinic workup as the gold standard here, and trying to develop different diagnostic algorithms that can be used for decision support. So I'm just going to show some pilot results from this study, where we have included 150 participants so far. Here I want to show that collecting plasma and handling it in primary care before sending it to your local hospital seemed to have no effect on measuring plasma p-tau 217, so it works as well from primary care samples compared to our best handling at the memory clinic. And also identifying amyloid positivity in a very heterogeneous primary care population. So here we have all individuals seeking help due to cognitive impairment. So it's a very heterogeneous population, but it seems to work very well to separate amyloid positive from amyloid negative individuals. Here defined as either CSF or amyloid PET with an AUC of 0.92. And also identifying Alzheimer's disease. And here we used a consensus diagnosis based on the latest AD criteria from 2021. So they also include CSF biomarkers. And we diagnosed it at the MCI and dementia stage. And as you can see, it's a fairly high AUC just using p-tau, but if you include also ApoE genotype and ADAS delayed recall, you have a accuracy of around 90% in this primary care population. So to conclude, maybe it's a bit of a bold statement, but in many ways, I think plasma p-tau seems to be one of the most promising plasma AD biomarkers so far. And it reflects both beta amyloid and tau pathology. In terms of different p-tau variants, p-tau 217 seems to perform slightly superior to p-tau 181, and mainly based on the higher dynamic range that it seems to continue increasing more and has a more fold increase. And p-tau 231, maybe it changes earlier than p-tau 181, but I think maybe the platform and type of antibody are more important in terms of what to choose here. And likely, I think we will see many different types of p-tau in the market in the coming years. Hopefully, at least here in Sweden, we will have it available in clinical practice later this year. And in terms of how to use it, I don't think this will be the one blood sample to use to check if you have Alzheimer or not. And definitely not just using one cutoff. I think we should be more flexible here and look at the levels a bit more. And maybe combining it, as I showed, with different cognitive measures, since you can have AD pathology for a very long time and possibly lifelong without developing cognitive symptoms. And also, it could be important for using in pre-screenings for Alzheimer's disease drug trials. I want to finish by showing such a scenario. Here is a tentative scenario where we have a disease-modifying treatment for Alzheimer's disease that should be initiated at an early point. So we want to identify individuals, preferably first in primary care, maybe using a similar to decision support algorithm as the one I showed, where you can get a measure of the probability of Alzheimer's disease, where you can give a reassuring message to those with a very low probability, and maybe refer those with moderate and high probability of Alzheimer's disease, where you could verify AD at a specialized memory clinic, do the pre-treatment evaluation, and then maybe start your disease-modifying treatment after that. Of course, a dream scenario, but I think this is where we should aim. Finally, I want to thank the entire research group. There are many, many important researchers that have contributed tremendously to many of these publications. And also, as I mentioned in the beginning, I will not, unfortunately, not be able to be available live, but I looked at the list of presenters and noticed that there were many competent and prominent names, several of them co-authors of the papers that I've mentioned. So I'm sure they can answer all your questions. Thank you so much. Bye.
Thank you very, very much, Dr. Palmquist. That was a superb presentation as well. So we have time for some questions, but Dr. Ashton was going to address them, and I wonder whether Nicholas is available.
Hello, yes, I'm here. Can you hear me?
Yes, we can hear you very well. Thank you very much. Good afternoon.
Yes, good Friday evening, yes.
All right, so you can perhaps see the first question on the screen now. Do you think the increasing permeability in the blood-brain barrier is the determinant of the p-tau showing up in the plasma, or is there really an increase in the production of p-tau in the entire body, I suppose?
Yeah, so it's an interesting question and something we don't fully know the answer to. I think that the mechanism is that we know that there is a turnover of CSF into the blood on a daily basis, and quite simply that the concentration of phosphorylated tau is higher in those that have Alzheimer's disease because of this release of phospho-tau to the brain to the CSF. We do know from acute disorders measuring phospho-tau, for instance, cardiac arrest, TBI, that there is a blood-brain barrier component here because phospho-tau levels shoot up in these individuals within 24 hours of an acute event. So there are different mechanisms at play, but thinking about Alzheimer's disease, I just think that the concentration of phosphorylated tau being turned over into the bloodstream is at high levels, and that's why we detect high levels in blood.
Okay, thank you very much. Any other questions from the audience here? All right, so if not, we are going to take a break now and reconvene here at 10:30, also to listen to Dr. Ashton. Thank you very much, Nicholas, for being with us.
Thank you.
All right, so we will continue with the morning session, and the next talk is on plasma neurofilament light, and we are very fortunate to have Dr. Nicholas Ashton, who has done pioneering work in this field, to discuss this topic. Now, Dr. Ashton is an assistant professor in the Department of Psychiatry and Neurochemistry at the University of Gothenburg in Sweden. So without any further ado, go ahead, please.
Thank you very much for the introduction. I hope you can see my slides and you can hear me fine. So it's really great to be in this symposium, and I want to thank everyone for their invite and for listening. My name is Nicholas Ashton. I'm from the University of Gothenburg, and here is a nice image of the west coast of Sweden on a good day. Usually it's very, very grey and rainy, just like London, where I'm originally from. So I haven't chosen well when it comes to weather. So I'll be talking about neurofilament light today, which I think is really the pioneer in this new generation of plasma biomarkers. It was really the first biomarker in blood to show meaningful relationships with CNS disorders. And there's a number of reasons for this, but it's a combination of advanced technology and well-characterized research cohorts. So I'll be talking about neurofilament light today. I have nothing relevant to disclose for this lecture. So some of the objectives today, there's a whole host of data about neurofilament out there, so I want to condense it into some few key points here. And very brief over about the basic structure and function of what neurofilaments light are in the brain and what happens in cerebral spinal fluid, and then moving very quickly on to the immunoassays that detect neurofilament light in plasma, and this is quite a pioneering technology which is now widely used for phosphorylated tau and GFAP and many other biomarkers now. And then we'll look at neurofilament light and neurodegenerative disorders. What does it mean for clinicians? What does a high level of neurofilament light mean, and what can it be used for? And this is a symposium about Alzheimer's disease, so I want to look at neurofilament light into relation to meaningful pathology in Alzheimer's disease in isolation. And I think that we can't move on without looking at NFL in other neurological disorders. It's a really great biomarker in acute disorders. And then some food for thought about peripheral confounders of neurofilament light. If we are looking at neurofilament light in clinics or in research, what do we need to consider? And this is things that happen in the periphery. I've already spoiled it, but we can still talk about it. And then some pre-analytical and stability considerations for neurofilament light and the possibility of remote testing. So neurofilaments are ubiquitous in the brain. They're one of the most abundant proteins in the brain, and there are different types. Neurofilament, my pointer here. Great. So neurofilament here is what we'll be talking about today. It's about 770 kilodaltons in size, but we have neurofilament medium and heavy, and this alpha interconnection and peripherin, which is exclusively expressed in the periphery. And they have different sizes, but they have very similar functions, and they also have very similar makeup in terms of the amino acid sequence. And we don't exactly know, but we believe that it's these coil areas and the rod area that we measure in the biofluids for our immunoassays. It's very similar antibodies that are used in all these immunoassays that I'm going to talk about, and they pick up this area here. And it's this biomarker here, neurofilament light, which we are looking at. Neurofilament heavy is also something which is extensively looked at in blood and has been compared many times to neurofilament light, but it seems that neurofilament light has the better sensitivity and specificity when measuring neurodegeneration. So they are concentrated neurofilament light proteins in these large caliber white myelin axon sheath. And when there's axonal injury, regardless of what pathology that is reacting to, these neurofilament light and other neurofilament chains are released into the CSF and, of course, then released into the blood. And it's believed that it's about 100-fold difference between the concentrations in CSF to the concentrations that are in blood. So that's why we need extremely sensitive assays in order to pick these up. So we believe that it's a general indicator of axonal damage, and I'll give evidence to why we believe that. But there is also a normal aging increase of neurofilament in biofluids. So without any known pathology, there is about a 2.5-fold increase from the ages of 20 to 50. And then between 50 and 70, there's a further 2-fold increase. So this could be just a product of age-related neurodegeneration, non-specific. But we know there's this phenomenon of a reduced CSF turnover with age. So maybe just the concentration of neurofilament light is increasing because of the lack of turnover. So a quick comment about cerebral spinal fluid and neurofilament light. And Sebastian and Susan have already spoken about the advantages of plasma, so I don't need to go into why CSF is not used routinely in clinic. But we have this ATN criteria, which Sebastian has also already introduced us, where amyloid is depicted by PET or by CSF, amyloid beta 4240, tangle pathology by tau PET and phosphorylated tau. But then we have these neurodegeneration markers, so MRI and FDG PET, glucose metabolism are these biomarkers for neurodegeneration, but we have total tau and neurofilament light as the CSF candidates. So this is what NFL and CSF looks like in a range of disorders. You can see that late onset Alzheimer's disease here is really in the middle and has quite mild changes compared to healthy controls. And mainly cognitive impairment disorders have mild changes in neurofilament light, whereas more aggressive disorders with maybe more white matter pathology or more intense neurodegeneration like FTD or vascular dementia have larger increases. And before we move on further, neurofilament light, I want to make a comment about total tau as a biomarker. We haven't discussed total tau, we've only discussed phospho-tau, and it is in our ATN criteria a marker of neurodegeneration. And while that might be true for Alzheimer's disease, it's certainly not true for other neurodegenerative disorders because it only increases in Alzheimer's disease, which you can see from this plot here. Large increases in total tau for late onset Alzheimer's disease and mixed dementias, but frontotemporal dementia and dementia Lewy bodies, they are at the levels of healthy controls. Now, there are some cases where total tau does change, and that is in CJD. It's big increases in CJD in total tau, whereas phosphorylated tau stays normal. And this is where the idea that total tau is a marker of neurodegeneration. But I think the field is now agreed that neurofilament light is a better global measure of neurodegeneration. And the same is true for, well, it's actually not true. The plasma total tau as a biomarker does not work very well in Alzheimer's disease. There are significant increases, you can see from this plot on the left-hand side. But the overlaps are extremely large, and the correlation between plasma total tau and CSF total tau is, I would argue, non-existent. So in plasma, definitely a marker of neurodegeneration is neurofilament light. So this is the technology that pioneered the detection of neurofilament light in plasma. Our normal immunoassays, ELISA assays, could detect neurofilament light in plasma if there were very, very high concentrations. But in order to get a more global picture of neurofilament light, we needed a more sensitive technique. And this is the Simoa technology. And it's based on a sandwich immunoassay, just like most of our ELISA assays. But there's one fundamental difference, is that this immunocomplex happens on a bead. And then there is a disc in the Simoa where there is 300,000 wells. And these wells are only large enough to fit one bead. So this picture here in D shows us that if there is an immunocomplex, say for neurofilament light, which is pulled down into the well, it will light up in the immunoreaction. If there's no complex, it will stay dark. And this means that you can simply do single molecular counting. So if there's 300,000 wells and only one of them is lit up, in principle, that is a quantifiable measure, and that's what makes it so sensitive and has a large dynamic range. So this is just to show you as a comparison between conventional ELISAs and the Simoa platform, is that we believe that there's about 100% fold improvement on sensitivity, and that means that we can detect neurofilament light of all people, of all conditions, even healthy controls, all the way down to children as well. So we can characterize almost everyone using plasma neurofilament light or serum neurofilament light. And this is one of the figures that really kind of changed the belief of many people that didn't think blood biomarkers would work. And that's what we started to see quite a good correlation between a biomarker in blood and a biomarker in CSF, meaning that we could infer on a CNS disease by a blood disorder. Now, this great correlation isn't always the case. This is a best case scenario, I think, and we'll talk about that later on. Now we have other immunoassays to detect NFL, and I think what Susan and what Sebastian were pointing out is that the assay really mattered for these biomarkers. But these plots here show that this is not the case for neurofilament light. We have different platforms using different technologies. Most of them are using similar antibody combinations, which may be the reason, but as you can see that the correlation is excellent. So even if you have patient samples or you have artificially spiked NFL, the correlations between many different platforms are very, very good for neurofilament light, which is great for the field. So I want to move on quickly to what does NFL mean in primary care. We've seen that phosphorylated tau and A-beta have great utility in detecting Alzheimer's disease dementia and also future risk. But these are studies from the ADNI cohort. So this is a freely downloadable database which you can look at neurofilament light and many other biomarkers. And as we can see from these box plots on the left-hand side, that there is only mild increases in plasma NFL compared to control, just like I explained for CSF earlier. And while the area under the curves are quite impressive, I think that as clinicians, we wouldn't trust a biomarker here which has this much overlap. But we looked at a large study here. This is something we released last year, and this is 2 independent cohorts over 2,000 individuals, but looking at not just Alzheimer's disease, but 15 clinical syndromes and healthy controls. And really, we wanted to compare the levels. Were they comparable when you go from one cohort to another? And what disorders really start to show meaningful differences in neurofilament light? So we have a whole bunch of people in what we call preclinical or Alzheimer's disease syndrome here, Alzheimer's continuum, sorry, but also frontotemporal dementia, Parkinsonian disorders, including CBS and PSP, also Down syndrome patients, but also Down syndrome patients that have a confirmed diagnosis of Alzheimer's disease, ALS, and also people with individuals that are suffering from clinical depression. So cohort 1 on this side and cohort 2 on the other side, very similar conditions, and as you can see, very, very similar patterns. We can see that the cognitively unimpaired individuals are the lowest, and then we have this increasing scale of neurofilament light levels through cognitive impairment disorders, peaking at frontotemporal dementia, which is seen to have a more aggressive neurodegenerative output, and this is very similar to the CSF panel that I showed, and this is repeated on this slide. Parkinsonian disorders are extremely interesting. As you can see, that we have pure Parkinsonian types here, but you have an atypical Parkinsonian disorders like cortical basal syndrome or progressive supranuclear palsy. Levels of neurofilament light are extremely high, and this is replicated in both studies, and we also have multiple system atrophy here in this cohort. So this shows us that this is an extremely powerful use of neurofilament light, being able to separate Parkinsonian disorders, those that are having a more aggressive atypical type, or those that have a pure Parkinsonian type. You can see the Parkinson's disease dementia and DLB are grouped into one here, and they have also sort of an intermediate level between atypical Parkinsonian disorders and Parkinson's disease. Just to really contrast these two plots, this is phosphorylated tau 217, and we can see that there are similar disorders shown here where there are big increases in Alzheimer's disease and Alzheimer's disease phenotypes, whereas these atypical Parkinsonian disorders are very, very low, unless they have amyloid pathology shown by these green dots, then 217 is high. So there's a very different profile between neurofilament light and phosphorylated tau across the neurodegenerative disease spectrum. And this is also now shown by this heat map of area under the curves. And most of these area under the curves, when you compare disorders, are extremely modest. So in the blue and the yellows, no higher than 80%, or in most cases less than 60%. But separating atypical Parkinsonian disorders from Parkinson's disease, there is a very, very high area under the curve and a very good sensitivity and specificity in order to determine this. Last thing on this plot I want to point out is the difference between individuals with Down syndrome and those with Down syndrome dementia, an extremely different profile of neurofilament light. And this is very important in this population, given that there is such a wide ranging of intellectual abilities that cognitive tests are not always sensitive enough to understand if cognitive impairment is at play. So in the same study, we've been trying to look at cutoffs. What is meaningful cutoff for neurofilament light? What means neurodegeneration and what doesn't? And I want to show here basically the difference between those that are over 65 and those that are under 65. So we can see on the over 65 with these red bars, which means that you have high levels of, what we would classify as abnormal levels of neurofilament light, but the same disorders in under 65. A lot more individuals are classified as abnormal if they're under 65. And this is because of this great age effect of neurofilament light and age, and it's not linear across aging as well. So this is a study that we have done in our clinics. Here, these are all people that are cognitively unimpaired, so they're either partners of people that have come in with cognitive disorders, so they have no neurodegeneration, and we're looking to see what are the normal levels in aging. And these are our defined cutoffs, so this is based on almost 2,000 cognitively unimpaired individuals. And you can see that the normal levels, this is characterized by 95% confidence interval, that it increasingly the cutoff increases with age, but then really starts to increase dramatically when you hit 70 years of age. And this lowest plot is the same, but showing it that there is a really exponential increase of kind of what we would call normal levels of neurofilament light. And the levels start to get more sporadic. So there's really an age effect of neurofilament light coming into biofluids that we need to consider if you're assessing, using neurofilament light as an assessment tool in clinics. And the last point from this data set I wanted to take away, again, is talking about the age effect. So in plot A here, looking at the red area under the curve, this is just to separate individuals who have no cognitive impairment, no complaints, from those that have a neurodegenerative disorder of any type. And we can see in over 65, the area under the curve is 0.8. It's good, but it's quite modest. But if you look at the same conditions, but just narrow the age range to those that are under 65, the area under the curve goes to 0.9, and it's much, much better. Now, point C is an extremely important figure, I feel, is that now we're looking at those that have come into clinics with onset of clinical depression or a primary psychiatric disorder, which we know is much more common in early onset neurodegenerative disorders. And we can see that the accuracy of neurofilament light to separate those that have a neurodegenerative disorders or those that have a primary psychiatric disorder is extremely high at 0.95. And this could be an extremely useful tool for early onset dementia types, thinking particularly for frontal temporal dementia. So in primary care, there's this profile here which I'd like for us to look at. And this is adapted from Anton Luzny's paper in JAMA Neurology, where he used tau PET, but I've replaced them with blood biomarkers. And I think the main thing is that in primary care, we have to put these blood tests in context with the clinical symptoms of the patient. For instance, you may have a clear FTD phenotype, but your blood phospho-tau measure may come positive. And that means that there's not a misdiagnosis. This means that there is Alzheimer's disease pathology at play, but the clinical syndrome is still FTD. So you really need to put these blood biomarkers in context. But if AD is one of the differential diagnoses of a patient, I think we're seeing quite substantial evidence, and it will continue to improve, that blood phosphorylated tau is a diagnostic tool for Alzheimer's disease dementia if it fits the clinical opinion of the clinician. On the other side, what if phosphorylated tau is negative? In combination with blood NFL, if this is positive, I think this very rapidly suggests to a clinician that there is a different neurodegenerative aspect at play, and this could really speed up the process for further investigation. So negative phosphorylated tau kind of rules out Alzheimer's disease type pathology. Positive NFL suggests that maybe it's a vascular dementia or dementia Lewy body or FTD type, and we have more advanced imaging which could confirm this. And I've just added on a second here, what if both these blood biomarkers are negative? Well, again, you have to put this in context with what the patient is presenting, but it could mean a primary psychiatric disorder or something else which is treatable that could be at play. So I think these blood biomarkers are starting to be really meaningful in terms of primary care. So just to conclude this first section is that really, although Alzheimer's disease and neurofilament light is the most two common terms put together, NFL is only really mildly elevated in Alzheimer's disease. And if you have a high level of neurofilament light in the context of Alzheimer's disease diagnosis, I think that this is actually a red flag, and there is something else going on in tandem with the Alzheimer's disease dementia diagnosis. But it is clinically useful in identifying atypical Parkinsonian disorders, also dementia within the Down syndrome population, and as I said before, just that frontotemporal dementia patients with cognitive impairment present with much higher levels of neurofilament light. Age is a really, really important consideration when taking this into account. Neurofilament light seems to shoot off of around 70 years of age, so you cannot compare a person at the age of 60 to those that are 75 with the same cutoff, and this needs to be considered. And I think that a very useful component would be that to separate neuropsychiatric syndromes and psychiatric syndromes presenting as an onset of a neurodegenerative disorder. So one aspect that I think is very important to consider is preclinical Alzheimer's disease, and phosphorylated tau and A-beta in blood have been shown to work very well at the preclinical stages of Alzheimer's disease, and this is very, very important for clinical trials, of course. But how does neurofilament light compare when we're looking at preclinical Alzheimer's disease? This is from the alpha cohort in Barcelona. This is a completely cognitively unimpaired individual, but they are classified with having no pathology, amyloid pathology, both amyloid or tau, or just tau. And this is CSF neurofilament light. And we can see that even though they have no symptoms, if amyloid and tau is present, neurofilament light is high. Now, if you contrast this with blood biomarkers, neurofilament light here is at the bottom. Here, we can see that these are the same patient with the same profile, and you can see that neurofilament light at this A+, T+ level is, well, it's significantly increased, but I think that you looking from quite far there will not be able to see any differences. I certainly can't, and I'm quite close to the screen. So I think that it is important to, here is the first thing to distinguish that plasma NFL and CSF NFL correlated very, very well, but there are very subtle differences, and preclinical Alzheimer's disease is that subtle difference. Just to look at the other results here, we can actually see that these phosphorylated tau, even in preclinical Alzheimer's disease, are starting to increase, even if there's subtle amyloid pathology, even without tau. And this is also the case for GFAP. So these are very good preclinical biomarkers. And this is just a summary plot of this cross-sectional data showing that neurofilament light in the preclinical stages is only very mildly changes, where other markers of specific to disease pathology are changed. And this makes total sense, that neurofilament light is a marker of neurodegeneration. So when there's atrophy and over cognitive impairment, that's when neurofilament starts to change. So 2 points on preclinical AD. NFL is elevated in CSF preclinically when tau is present, but this is not reflected in plasma. So only very small changes, around about 10% in this population. So if you were to have an individual with cognitive unimpairment, but very high levels of neurofilament light, this is a very strong indication that something acutely wrong is going on. So now I want to look in relation to pathology. So I'm looking at Alzheimer's disease in isolation. I've talked about that neurofilament light is only mildly increased in Alzheimer's disease comparative to other disorders. But if you take the Alzheimer's disease continuum in isolation, how does it track different types of disease pathology? So the first thing we have done here is look at post-mortem pathology. So how does neurofilament light reflect post-mortem pathology? So 2 to 4 years before death, you can see that there's a stepwise increase in plasma neurofilament levels in relation to BRAC, so more tau pathology, more NFL. That makes total sense based on in vivo data, but now shown with neuropathology data. And this is quite a nice crude way of showing that plasma neurofilament light is reflecting white matter tract degeneration in an Alzheimer's disease brain. So we have BRAC stage 1, so low tau, to BRAC stage 6, which is high tau, and this is stained neurofilament in this white matter tracts, and you can see how this intensity of staining decreases as Alzheimer's disease pathology progresses. And there's this inverse correlation between the levels of neurofilament light close to postmortem and the levels of staining at postmortem. So high neurofilament light levels, very low percentage staining for neurofilaments in the white matter tracts. So a very crude neuropathological confirmation of neurofilament light. So we can look at this now in vivo. So here are some correlation voxel-wise plots, and if you're not familiar with this, you can just think about these images as visual correlations. So one measure of plasma neurofilament light and how they are correlating to different regions of pathology in the brain. So this first plot is grey matter pathology, and on the left-hand side we have cognitively unimpaired individuals and cognitively impaired individuals separated by ApoE genotype. And we can see that there are small clusters of associations between neurofilament light and reduced grey matter pathology, but it's quite subtle. There's a bit more of an overt association in cognitive impairment, particularly in the hippocampus region here as well, and prefrontal cortex and medial temporal gyrus. But what we can see, there's a very subtle difference, or a very clear difference actually, is that in ApoE carriers, NFL and grey matter reduction is very clear in cognitively unimpaired individuals, but this is not the case in cognitively impaired individuals. So this here on the right-hand side shows us the kind of generalization of neurofilament light to pathology. But when there's no symptoms, but we know that ApoE is linked to amyloid, and amyloid starts accumulating many years before symptoms, I think this is why we start to see this quite strong association that the NFL is reacting to amyloid pathology. Now, if we look at longitudinal measures, so levels of neurofilament light across a number of months or a number of years, and also grey matter pathology over a number of years, we can see that the association in very meaningful areas of Alzheimer's disease pathology where reduced atrophy is occurring, there is an association between plasma and grey matter pathology, again in the hippocampus and the frontal cortex. So this is cognitively unimpaired individuals, and this is a schematic timeline in impaired individuals, and you can see that this is increasing. And this is just in comparison with other biomarkers here, just to illustrate this, that there is a mild association between neurofilament light and grey matter pathology in Alzheimer's disease, but it's really picked up much better by phosphorylated tau and A beta 4240. So really just to illustrate that they are associated, but it's better reflected by other biomarkers. But this is where the story starts to change. White matter pathology. I spoke at the start that neurofilament is highly concentrated in white matter, large caliber axons, and we can start to see the stark correlation and difference between white matter pathology and neurofilament light in cognitively unimpaired people, cognitively impaired people, and cognitively unimpaired people, and how this starts to progress over the time course of the disease. It's a very stark difference and quite a global association between white matter reduction and increased plasma neurofilament light. And this is in the cognitively impaired group, and again, the associations are extremely stark compared to the associations that we looked before with grey matter pathology. Now, another measure of neurodegeneration is glucose metabolism in the brain. It is one of the N in our ATN criteria, and we've looked at this as well in relation to neurofilament light. And we've also compared it with neurofilament light in CSF. And what is quite nice to see is that if you look at cognitively impaired group or unimpaired group, that the patterns between plasma and CSF are quite similar. It actually looks a little bit stronger here for plasma, but I think this is the sample size effect. So that's a quite nice validation that what we're reflecting in plasma is what we also see in CSF. Now, if you look at the impaired group, and these are separated by people that have amyloid in the brain and people that do not have amyloid in the brain, you can see that glucose metabolism and NFL have a very large association, and this is restricted to areas that are accumulating amyloid, which makes a lot of sense. But this shows that the non-specificity of neurofilament light, that if you don't have amyloid, there are still associations between glucose metabolism and NFL in the frontal region. So this would indicate a frontal temporal type dementia as well. And the last comment on pathology in terms of in vivo imaging is in relation to amyloid PET and tau PET. And this we've done here in cognitively unimpaired individuals in the ADNI cohort and triad. So this is amyloid, this figure here. And we can see that there are associations in amyloid associating regions like the precuneus and posterior cingulate. But again, they're quite mild. But if you look at cognitively impaired and with tau PET, you can see that the change in plasma neurofilament light and the change in tau are much more associated. And again, this is in fitting with plasma neurofilament light being a biomarker of neurodegeneration and tau PET being a later pathology which is more related to cognitive symptoms. Now, this is also in the ADNI cohort here in a different paper classifying by the ATN. And you can see that levels of neurofilament light change are only increased in individuals with tau or N positive in these two bar charts here. If you're amyloid positive but you're tau N negative, you can see that the rate of neurofilament light does not change compared to those that have no pathology at all. Now, I want to circle back to neuropathology now because I've only really talked about disorders in Alzheimer's disease. Of course, there are many other pathologies, but we don't have much in vivo in the way of in vivo imaging for them. But so we have a cohort where we've had longitudinal plasma taken throughout life and a very detailed neuropathological assessment. This is with Doug Glasgow's group at UC Davis. And this is typical Alzheimer's disease pathology by this ADNC criteria. I just want you to pay your attention to the phosphorylated tau and NFL here. So we can see that with increasing Alzheimer's disease pathology, the phosphorylated tau increase. But if you have other pathologies or other pathologies plus intermediate Alzheimer's disease, they are low. If you have a dual pathology in Alzheimer's disease and something else, then they are still the same levels if you had Alzheimer's disease pathology. So having TDP-43 pathology or alpha-synuclein is not increasing your phosphorylated tau. But what you can see from the NFL is that they're pretty uniform across whatever pathology you have. So it has this non-specific and ubiquitous increase in many different disorders. If we look at this in more detail, again, I just want for you to pay your attention to phosphorylated tau and NFL. This is hippocampal sclerosis. So Alzheimer's disease pathology and Alzheimer's disease pathology plus hippocampal sclerosis, phosphorylated tau are increased, but just hippocampal sclerosis alone, it's decreased. NFL, it's opposite. It starts to increase with hippocampal atrophy, the hippocampal sclerosis, sorry. Looking at TDP-43 pathology, you see the same pattern. No increases in phosphorylated tau in the blood if you have TDP-43 as a pure disorder post-mortem, whereas in NFL, there are no changes. There are increased regardless. And lastly, in the same way, Lewy body dementia, less of a change, but it's still decreased in Lewy body pure pathologies, whereas neurofilament light is unchanged. Now, this is different for cerebral amyloid angiopathy, where this doesn't seem to change our biomarkers at all. So if you have no mild or severe CAA, the phospho-tau biomarkers are changed. There seems to be a little change in 231, but there's definitely no change in NFL. Now, what if you have a pure pathology? So I'm thinking here about familial Alzheimer's disease and Down syndrome dementia. You can see that neurofilament light starts to increase about 5 years before symptom onset in these mutation carriers versus non-mutation carriers. So it's later than phosphorylated tau, as Sebastian showed us before. And we can see that these increases are quite dramatic when you look at the individual there. And the similar case can be seen for Down syndrome dementia. These scales have been cut off here, so sorry about this. But the divergence here starts to happen around about 40 years of age, and it's very, very clear at 50 years of age. in Down syndrome population versus people without. So the conclusions of this section is that NFL is only mildly related to grey matter pathology, but reflects quite intensely white matter pathology in the brain, and it's strongly associated with FDG PET, so glucose metabolism, even in the non-AD cases. And there's a mild association with amyloid pathology, but the longitudinal relationship is better with tau. And NFL can reflect TDP-43, hippocampal sclerosis, and Lewy body dementia, but is not increased with cerebral amyloid angiopathy. So I have a few more minutes left, so I just want to look at NFL in some other disorders, and this one I want to look at acute neurological disorders. And my research is very focused on Alzheimer's disease, but when I started to look at neurofilament light in collaboration with people with out-of-hospital cardiac arrest, I was really astounded about how well this biomarker works to predict prognostic, for the prognostic performance of individuals 6 months later. So these are individuals that have had an out-of-hospital cardiac arrest. We can see that at the time of emission, so at 0 hours, that neurofilament light has barely changed. But after 24 hours, if you have a cerebral performance score of above 3, so this is severe neurological injury which will be sustained throughout life, you can see the dramatic changes of neurofilament light. So at this very early stages, at 24 hours, when someone is unconscious after a cardiac arrest, neurofilament light is an extremely good biomarker to assess what is the likely scenario of this individual having a good outcome. And this is a very important clinical consideration in acute disorders. Traumatic brain injury is something we've looked at neurofilament light as well. This is in relation to GFAP here, but we can see that after 6 months after a traumatic brain event, neurofilament light is extremely high still. This is the individual plots here, that even at around about 40 or 60 months after the event, neurofilament light levels in plasma are very, very high. So 60, to put this in perspective, a dementia diagnosis kind of area of someone that's 75 is around about 30 picograms per mil. And these individuals are double that, even 60 months after the injury. Curiously, and something we haven't explained yet, is that GFAP starts to increase at the same rate. So this could be some developing astrocytic injury, but we're not too sure about that. So we can't have a presentation without mentioning COVID-19, of course. And we've looked at neurofilament light in this scenario as well. And we can see that in the acute phase of the disease, there is no change in neurofilament light between mild and moderate individuals. But in severe individuals, neurofilament light is increasing quite dramatically over a number of days. And first of all, this was a concern that this might be some ongoing brain injury, but I still think that this is a response to hypoxia, because most of these individuals that have severe COVID-19 will probably be on oxygen supplementation or an ICU. And you can see that all these individuals have come back into normal ranges, but it took quite a long time for this to happen. And this is another study where we looked at COVID-19, but considering peripheral neuropathies as well. I just want to point out here is that in the controls, there is a nice correlation between CSF NfL and serum NfL. But in COVID-19 neurological cases, this relationship is disrupted. And this is purely down to that in plasma, if you have COVID-19 but a peripheral neuropathy like a Guillain-Barré syndrome or something similar, plasma NfL is increased very, very highly. But the CSF NfL is not. So there is this disconnect between periphery and CNS, which is reflected in NFL, and it could be one of our confounders that we will talk about in a bit. This is just a super cool study. I'm very proud to always present it. It has nothing to do with acute neurological disorders, but we've been working with astronauts from the European Space Station, European Space Agency, and we've been measuring their blood biomarkers before and after they've had time at the space station. And we can see that neurofilament light here at baseline and after 1 week after returning to Earth, that it's significantly increased. And this is quite, although it's quite mild, this is in line with their MRI, where they are showing quite acute MS-like lesions after coming back, which disappear after a number of months. So NFL is a dynamic biomarker, and it changes either with rest or with an effective intervention, which I think Charlotte Tennyson will talk about. So this is another interesting study where we've looked at boxers before, after a bout, and then after rest. And we can see that NFL really dramatically changes, but normalizes itself if you're resting. And you can see that the Alzheimer's disease biomarkers, phosphorylated tau and A-beta, stay normal. And it's quite clear to see from this graph who are the good boxers and who are the bad boxers by the levels of neurofilament light directly after the bout. And this is one particular case that we've been following. They were knocked out in April 2012 in an amateur boxing fight, and the levels of neurofilament light were taken 10 days later, and they were extremely dangerous levels. And it took almost 8 months for them to come back into an age range level for them for neurofilament light. There was a plateau here, and we found out that they actually went back sparring there, so it's likely they were continuing to be hit in the head, which delayed the onset. So it just shows the dynamics of neurofilament light and how it shows ongoing neurodegeneration. And there's some cases here with effective intervention. So this is natalizumab in multiple sclerosis patients. So after 12 months, neurofilament light levels have gone from pre-treatment to after treatment close to controls. And here also in spinal muscular atrophy patients here, so young children here with spinal muscular atrophy, how they respond to an effective drug and how it reduces neurofilament light levels. This is in CSF, I must say. The peripheral confounders, so this is correlation plots which are not quite as nice as the first one I showed you. So good correlations, something we never saw before with a blood biomarker, but they are still not perfect. So what are the reasons for this? Well, of course, this is a blood biomarker, maybe not the whole amount of NFL is coming from the CNS into the blood, but there are some very important peripheral confounders, and one of them would be renal function. So plasma NFL and serum creatinine have quite a good relationship. So a poor renal function increases plasma neurofilament light, but not CSF neurofilament light. And I showed you earlier in the CSF, in the COVID-19 patients, about how peripheral neuropathies can increase neurofilament light in the plasma, but not CSF. And this is Charcot-Marie-Tooth syndrome. So in the matter of time, I'll just skip that and I'll go straight onto the stability of blood NFL. So one of the most attractive things about blood NFL is it's extremely stable. You can really mistreat a blood sample and you cannot change the levels of neurofilament light. And it's a major advantage. So this is a paper published by Charlotte Tennyson, and maybe she will talk about it in more detail. But if you are looking to collect blood, or you're wondering how to process or store blood for a study or in clinical routine, then there are now recommendations for a working group. But if you're just interested in NFL, really you can do whatever you want to it. One thing you need to be aware of is that we recommend to sample EDTA for neurofilament light and for all biomarkers, but the concentrations are different if you use citrate, heparin, and serum is very much the same. But the correlation between them are extremely good, so you just need a correction factor if you are collecting lithium heparin blood or citrate blood. But we recommend that EDTA plasma works well for all blood biomarkers that we've spoken about today. Freeze-thaw cycling doesn't affect neurofilament light, so it's the yellow one here, so up to four freeze-thaw cycles is very good. And also centrifugation temperatures when you process the blood is something very important. How important is it to centrifuge the blood quickly and at what temperature? And this does not affect neurofilament light either. And what about remote blood testing? Now, because of the stability of neurofilament light, it offers an opportunity for us to collect in remote areas, and also thinking about the recent pandemic when we cannot get patients into a clinic or we cannot visit patients. So we've done this study here using this blood spot analysis, where you spot whole blood onto this card and it extracts plasma just by automatically through this filtration system. And this is then saved on a card as a dry blood spot, and it can stay there for days. So we've looked at this blood spot, which is called Noviplex. This is this red plot here, versus our conventional version. So these are the same individuals that have had their neurofilament light measured and processed in our standard and careful way, and also in Noviplex. And you can see that the correlation is extremely nice. This is another version of the dry blood spot that didn't work so well. But you can see that the concentration differences are very different, very low in the Noviplex because you have to dilute so much to extract the plasma. But the relationship is excellent. One other consideration is that we've done an extreme delay. So we've just left whole blood in the EDAT tube for 48 hours on the bench. And even then, when you then process it and measure neurofilament light, the levels are identical to what you would have got if you'd measured them at 2 hours in the perfect way, and the levels do not change. And we confirm this again in a separate cohort, so seeing that Noviplex and plasma NFL work very well. Also, if you were to heat the sample, so we're trying to mimic really extreme conditions, remote areas, collecting blood, not processing it 48 hours at very hot temperatures, and still we could not change the levels of plasma neurofilament light. So it's a really robust biomarker, which gives it a major advantage. I think we don't really have the same information yet for phosphorylated tau and A-beta, but I don't think it would survive these kind of conditions. So this conclusion here, the pre-analytical performance here is that NFL is super robust. It's a stable biofluid and is unaffected by freeze thawing and other parameters like heat. The diagnostic cutoffs will be comparable from plasma to EDCA, but you need to think about different ways to treat heat, heparin, and citrulline plasma if that's a problem. And I think that NFL is a really good candidate for remote testing. So it's extremely stable for 48 hours in a blood tube, really at high temperatures, and this blood spot analysis where you could send blood spot cards out for home testing, or you don't even need to think about a venipuncture if that's something that is of concern to a patient, or multiple different scenarios you can imagine here are possible. One caveat is that we have only tested this with venous blood, so we're not quite sure whether capillary blood, maybe from a finger, is possible, but it has tremendous capabilities. So I think I'm a little bit over, so I just want to conclude and just point out some main things here, is that plasma neurofilament light has specific and isolated rules in clinical routine in atypical Parkinsonian disorders and frontotemporal dementia, and as kind of an alternative diagnosis with phosphorylated tau is coming back negative. As I said, so in combination with p-tau and NFL is likely to be a powerful first-in-line assessment for cognitive complaints in primary care, and because they can come from the same blood test, you can measure them at the same time. It's no problem. So NFL tracks only certain types of AD pathology, particularly white matter disease, tau pathology, and glucose metabolism. And this is also tracked in non-AD pathologies. And it's extremely important in the prognosis for acute neurological disorders. I think this is one of the best uses for neurofilament light. And the stability of NFL makes an attractive biomarker for remote testing and maybe self-testing, but that has some ethical considerations, of course. So a large team of people that have accumulated this work in NFL, particularly I just want to thank those at our Department of Neurochemistry in Gothenburg, and Kai Brunel and Henrik Zetterberg. And thank you for listening, and I'll be happy to take any questions.
Okay, thank you very, very much, Dr. Ashton, for that sweeping presentation on this extremely interesting biomarker. Do we have any questions online? I had a comment to make, particularly relevant for those of us who work with older people who develop dementing disorders, and is that many years ago, Dr. MacDonald Critchley already indicated those findings in older people who appear in completely neurologically normal individuals, for instance, absent vibratory sense in the lower extremities and so on. And of course, the question is how normal is an individual with this problem, right? So I think the availability of NFL is going to really be a tremendous tool for neurologists who are interested in geriatric patients. If questions online, do you think the increasing permeability in the blood-brain barrier is the determinant of the P2 showing up? Okay, this is a question that we had before, was answered already. All right. The next question is really about AFib42. Okay.
Everyone must be convinced with the data from neurofilament light, I think.
If you want to address them, you go ahead, Dr. Ashton.
To the bottom one about gut bacteria is that we don't know. Well, at least I don't know about this. Has been investigated with plasma phosphatase yet, and I think this is the next major thing for phosphatase. We don't really know what type of peripheral co-founders there are that will affect this biomarker. Tau is expressed peripherally. Phosphorylated tau we're not too sure about. It took us some time for us to show this data on NFL and creatinine. And the only way that we will get this data is by starting to test this in a quite a heterogeneous population. These research cohorts are quite well controlled and designed, so we don't get to examine this until we test it in real world scenarios. So I think we'll find out quite soon.
Very good. All right, well, thank you very, very much. We are going to move on to the next presentation on plasma biomarkers in the clinic and clinical trials. And for this, we are lucky to have Professor Sherlock Thunissen, who is a full professor at Amsterdam Neuroscience, Neurodegeneration, Neurochemistry Lab, Department of Clinical Chemistry. She is also a full professor in the university there. So without any further ado, Dr. Thunissen, please, very pleased to have you today.
Hello. I wish you all a very good day. My name is Charlotte Teunissen, and I will give a presentation on plasma biomarkers in the clinic and clinical trials. But first of all, I want to thank the organizers of this symposium for giving me the opportunity to share our data and also our insights with you. So here are my disclosures. And now I continue with the contents of the talk. And the contents of my talk is split in two parts. So I'll first discuss the state of the art in blood-based biomarkers for dementia, just shortly to refresh your mind, because this has been the subject of today already. And then I will allude on the road towards implementation. So first, to refresh your mind, the need for biomarkers. We do need biomarkers in Alzheimer's disease because there is a long preclinical phase. And during this preclinical stage, we're not able to measure the deterioration of a patient by means of clinical outcomes. But there is a biology ongoing. It's a time window of 20 years that gives us the opportunity to intervene, but also gives us the need to intervene. And therefore, we need biomarkers to be able to detect this ongoing biology. And we need those biomarkers to make an early and precise diagnosis of the specific proteinopathy that's ongoing. We need the biomarkers also to make a prediction of the prognosis. We want to inform the patients well. And we need the biomarkers also for monitoring. Biomarkers, especially in blood, are very flexible and cost effective. You can make multiple blood draws. So that's why it's relevant and easy, also convenient, to have blood-based biomarkers. We need also those biomarkers to monitor treatment effects, especially in this preclinical phase, because we can't rely on the clinical outcomes by definition. So probably we have to start to think about about the fact that we need biomarkers also to monitor the treatment outcome effects. And for Alzheimer's, we have fantastic biomarkers that we can measure in CSF or by PET imaging. And they are really the key proteins that are also the pathological hallmarks of Alzheimer's disease. So we are in a lucky position for that. But we can measure them in CSF and PET, but now we want to be able to measure them also in blood. And the previous speakers already indicated that we're able to do so. So this is a very exciting field. Just a few slides on plasma amyloid. So Suzanne Schindler already alluded on the use of mass spectrometry-based assays for Alzheimer biomarker detection. And we think that there is another technology that can have complementary information for that. And especially immunoassays are very convenient because you can multiplex easily. And immunoassays are methods that are available in every routine clinical lab. So we think that it's useful also to use immunoassays and have a wide portfolio of available assays for every different situation and your lab resources and needs. So we started to develop an immunoassay for amyloid beta that's specific of the A beta 1 to 42 and 40 assay. So this is the assay that's part of the N4PE kit that's now available via Simoa, via Quanterix on the Simoa machine. You see the machine over here. This Simoa technology allows you to multiplex also. So you can measure different Alzheimer relevant biomarkers simultaneously in one sample in a small volume, as low as 80 microliters. So that's a little. And here are some results showing that this multiplexing can add to the diagnostic sensitivity. So here we combined the amyloid analysis with the novel amyloid assay that we developed and is now available. And we combined it together with GFAP and neurofilament light. And you can see that this black line has the combined analysis of all these biomarkers leads to a higher diagnostic accuracy to detect amyloid positivity on PET. It's 88, so that's really a high sensitivity and specificity. So that's not the only added value of multiplex analysis. Those different biomarkers can give you also different kinds of information. So not only for diagnosis, but also for the relation with cognition, for example. So here you see results where we correlated the outcomes of the plasma biomarkers to different outcomes on cognitive scales, cognitive domains. And for every domain that we tested, you can observe that the plasma GFAP has the strongest beta, next NFL, and then amyloid beta 1 to 42. So GFAP here in purple seems to have some added value, and at least if you monotone language, here's the significance for GFAP and not for amyloids. So there is added value of all those different biomarkers. We dived a little bit further into the role and the relation of plasma GFAP and NFL with cognitive decline in a longitudinal follow-up study. In addition, we also measured amyloid levels. So we went back to the earliest stage of Alzheimer's disease, those of subjective cognitive decline or cognitive unimpaired individuals. And we measured the amyloid levels and related that to the progression to either MCI or dementia. And here we see that the lowest levels of the amyloid beta 42 to 40 ratio gave the strongest prediction of converting to either MCI or dementia. In those individuals, they don't have something on their cognitive testing, yet they do have Alzheimer biomarkers in CSF that are in agreement with Alzheimer's disease. So that was our endpoint, our confirmation of Alzheimer's pathology. In addition, we also measured GFAP and neurofilament light and how they related to the clinical dementia progression. Already at baseline, we observed differences in the levels of GFAP and neurofilament light in those who at follow-up became demented or non-demented. So at baseline, GFAP levels were higher in those who were demented at follow-up. And for neurofilament light, we see the same effect. If we again look at those survival plots, we see a nice dose-response relationship for GFAP, going from high, medium, and low. Low is a flat line, and for neurofilament light, we see a less strong relationship between those different quartiles. So GFAP seems to be a very good predictor of getting demented over years, and also for your rate of cognitive decline. So just a word on plasma beta. We heard about it before, so to refresh your memory, in different studies now it has been shown that p-tau and also all the isoforms of plasma p-tau, so 181 or 217, 231, they show specific increases in AD compared to older dementia. So here are several groups in the study of Lies Thijssen, where the levels of p-tau are lower than in AD. And the same tendency or the same pattern is observed also in this side-by-side published study, where again, plasma p-tau is increased and specifically increased in AD. So very convincing results. I do think that plasma p-tau, due to the magnitude of change, can also help us in monitoring of treatment effects. And this is a study that I copied from a slide of Mark Minton and presented at AIC last year, where he showed that the plasma p-tau levels were lowered over time. So you can see it at the plot at the right in donanemab treated patients, and a significant effect already at 12 weeks. And it moves on, and the maximum decrease is 24%. That's quite a lot. If you compare amyloid levels between Alzheimer's and controls, it's a difference of about 10 to 15%. So here for p-tau, we see higher increases also in the slides that I just presented you of the study of Lies Thijssen and Shorena Jale-Lietze, but we can also see that we're able to decrease it to a really substantial volume, so 25% decrease. So that gives a window of opportunity. So, and now after all those excitement, the question pops up, what shall we do or what do we need to do towards implementation either in the clinic or in clinical trials after these promising results? So it's relevant to understand what is the roadmap or the typical roads towards implementation of novel biomarkers. So in the first phase, we identify our biomarkers, and in the second phase, we have some initial validation, for example, against postmortem evaluation, and then in the third phase, we do larger studies, clinical studies in retrospective longitudinal studies, for example. And then when that's all positive, we continue with prospective studies in phase 4. And finally, in phase 5, we start implementation, or we start to finalize implementation, and there's a lot of work to be done. So this sounds very abstract, but what are some items that we need to do? What kind of studies? So that's depicted over here. So you see for every phase that we have different aspects that we have to address. And we divided it in primary aims. Here to the left, you can see this, and then the dotted line to separate them from the secondary aims. And we have aspects on the technical level and also on the clinical level in every aim and every phase. In this graph, you can also see where we are. So we made an indication. Green means that we met or addressed these aims already quite well. In orange is that, okay, still we addressed it to some extent, but still some studies are needed. And red means, okay, we have to start. So you can see that we are about halfway with the majority of biomarkers. If it's green in this zone, it's for the A-betas. So there is still a lot of work to be done. But we want to address that also in a concerted way, because we are aware of what needs to be done. And one of the issues, sorry, I've got to say, is definition of SOP, standard operating procedures for sample handling and storage. And it's green because we finalized to a large extent, and I'll show you some data. So these are the protocols, how to deal with your samples. And we found it very important because we were aware of the problems that we had with the CSF analysis. So now that we're able to measure those biomarkers in blood, we thought to address that as soon as possible. So here you see the results of a study in which we systematically addressed common pre-analytical variations. And one of these variations was that the sample was left at room temperature or on ice for a certain amount of time before it was centrifuged in a lab. And you can imagine you take a blood draw and then it's transported to a lab where they do the processing before it gets into the freezer. or it gets for further analysis. And we focused on 6 different assays for amyloid analysis. I will remove something from my presentation that you maybe not see, but here you can see the legend. So we have mass spectrometry assays in red, in orange and red, in gray and are the CIMOA assays, and we had in purple 2 types of ELISAs. Now going to the results, you can observe that after 1 hour waiting, 3 hour waiting, not really something happened, but then after 24 hours, we see the same effect in all the different assays that we applied. So amyloid levels within plasma are decreased by about 25% if left at 24 hours at room temperature before centrifugation. So that's a substantial reduction, especially if you imagine if you consider that the reduction in AD compared to controls is only 10 to 50%. The good news is what we see at the right over here, when we left the sample instead of at room temperature, now on cold in the freezer, or not in the freezer, sorry, in refrigerator or on ice, there we see complete abolishment of this effect. So that's the good news. And so that's what we know. Either we process the sample within 3 hours, or you have to put it on ice for the time being if you have a delay. Here's another aspect. We had multiple aspects that we addressed, but this is a variable that's often thought of as being very detrimental to biomarkers. Freezing thawing. So up to 4 times freezing thawing, we do not see an effect for the different biomarkers, for the amyloid biomarkers that we measured on the different assays. So I think that's the good news also. We included also other biomarkers. So this is a bit of a mixture, it's a bit more chaotic figure. There is one that really stands out. So we included GFP also, and neurofilament light in yellow, GFP in black, but total tau in purple, that's the outlier. So if you leave the sample at room temperature until centrifugation, we see a decrease. If you put it on ice, we see an increase. So this is a difficult assay, and this may explain the variable results that people obtained with this assay so far. So based on this information, these experiments and also other experiments, we developed this standard operating procedure that we published in Alzheimer's and Dementia last year. So here you can see what you need to do. The SOP is developed for EDTA plasma. If you can process within 3 hours, it doesn't matter room temperature or cold. But if you cannot manage it within 3 hours, please keep your samples cold. Then there is a centrifugation step, tube filling. These are the storage tubes that we also use for CSF analysis. And then for long-term storage, if you can store them, you need to store them only for 24 hours, you can do it cold. But if you have an extended period before your analysis or before you can storage your samples at -20, please do so at -80, sorry. Please do so at -20 if it's for up to 2 weeks, because that's what we tested. And please do not freeze thaw your samples too much, because for amyloid it doesn't matter, but for other biomarkers there may be some difference, like GFP we saw a faint increase when it's repeated freezing thawing over 2 times. So what now? Pre-analytics next. We're not there yet. We want to start up a second project, because we focused here really on amyloid. So what we now want to do is expand also some time points, for example, in between 3 and 24 hours. What's the bandwidth of keeping your samples at room temperature? Here are the other variables that we wish to test. But we want to include and focus really on p-tau assays, and therefore we want to include AD patients because they have higher levels of p-tau, so you have more bandwidth to observe some variation. So that's ongoing work. What further do we need to do and need to know? For example, a head-to-head comparison of platforms and biomarker isoforms. So for A beta, there are head-to-head comparisons already being performed between mass spectrometry assays and immunoassays, but that still needs to be performed for those other biomarkers. So what about p-tau? That's really an ongoing discussion. Which isoform do you have to choose to measure? For example, in the study of Nick Ashton, we do see that there is a difference in sensitivity to detect amyloid deposition by the different p-tau isoforms. So here you can observe that the plasma p-tau 231 is more sensitive than the p-tau 181 assay that had been used in this study. And the CSF p-tau 217, it's somewhere in between. So which isoform to choose? That's a question. Here are results from a study in which they, Lies Thijssen again, she compared the different p-tau 217 and the p-tau 181 assays from Lilly, side by side. And all conditions were kept the same, all conditions within the reagents also, except for the primary antibody that is specific for either the 217 or the 181 epitope. So for that detection. So it's a very reliable comparison. So you can see from the patterns in those box plots that it's about the same what they detect. And if you look at the areas under the curve, this is confirmed. So for example, in the comparison AD versus normal controls, so non-demented controls, we see a similar area under the curve for both p-tau 217 and 181. However, if you look for the comparison AD versus FTLD, so that's written over here in this lower side of this, or the right side of this lower graph, there we see a small significant difference in the direction that 217 might be better. But to be honest, an area under the curve over 93 or 91, that's not a big difference. So it can be statistically better. And if there was, and we did all kinds of comparisons in this study, if there was any difference, then it was always that the 217 was outperforming, but often there was no difference. And the difference in the area under the curve in performance was as small as you see in this figure D. We performed other head-to-head comparison of different p-tau isoform assays. Here they were all on the Simoa platform. So in the previous slide, it was on the MSD platform. It's not a big difference, but it's a difference. And we compared different assays from different providers. And we compared the analytical performance, but also the clinical performance. And here you see the results of the clinical performance of confirmed AD patients versus healthy controls. And we observed that it doesn't matter if you have 217 or 181, they have the same area under the curve. And the other assays, they performed a bit lower. So the ADX 181 is yellow, and the turquoise is the Eli Lilly 217 assay, but other assays were also 181 from Quanterix in this purple line. Now, they performed a little bit worse. And here, this line is for the p-tau 231 and that was from the reagents of ADX. So that version of the assay was not performing so well. But there are other things that you have to consider when you decide for a specific isoform of assay or specific assay that you may employ. And that's depicted over here. So you can look at the accuracy at low concentrations, because if you follow the green box, those two assays that happen to be the clinical best performing assays, they also have high CVs of the duplicates in the low concentrations. So that means that they are less accurate at the very low concentrations in healthy controls. And that's for this p-tau 181 of ADX, but also accounts for the p-tau 217 of Eli Lilly. But you have also to think of availability. And for now, only this Quanterix assay, p-tau 181, is available on a commercial basis, so everyone can buy it. Another consideration could be the detection in healthy individuals, because here we see that the 231 assays, they both perform best for measurement of p-tau levels of that isoform in healthy controls. So the overlap is a bit worse, but still you can measure them at least in healthy controls. So it's not yet decided, more or less, what you should do. It depends on your context. So the next step that we have to address for clinical implementation is the impact of covariates on the biomarker performance. And here's just one example of a study, because studies are still ongoing. But it can be patient-related factors, comorbidities, but also real confounders like ApoE, for example, or the blood pressure that can lead to difference in our results, that we have to take into account. And they can be of importance or not. And here in this multivariate analysis, they are all put in one model, so you can compare their relative importance. And I highlighted in blue the factors that really had an effect, a significant effect on the amyloid levels in plasma. So ApoE, hypertension, especially for the separate biomarkers, and especially in the AD patients. I think my legend dropped off. So I think in red are the AD patients and in blue the controls. And chronic kidney disease is really a confounder, not for the ratio that you can see at the right, but for the separate amyloid proteins. And chemotherapy also has an effect in the controls on their amyloid levels. And here you can see another graph. So Michelle Melky and her group, she also investigated the effect of those different confounders on neurofilament and light and total tau. Again, we see an effect of chronic kidney disease. So that's probably, it's a very relevant factor. It's also a high effect, a strong effect. And it's stronger that we see for total tau, neurofilament light being amyloid positive. Other factors for these biomarkers are stroke for neurofilament light and myocardial infection. Oh, and I made a mistake. And so red is cognitively unimpaired and blue is MCI. Another factor, confounder, is BMI. We observed an effect on both GFAP and neurofilament light and also on other proteins. So that is also a possible confounder of our results. It leads to lower concentration of those biomarkers, probably a dilution effect because you have a larger body mass to divide your biomarkers on. And the last few slides I want to dedicate to the context of use. That's also one of the aspects that we need to address. So when do we want to biomarkers, in which situation for all those different biomarkers in Alzheimer's disease, and in where? So here it's an open question. I think we have not yet defined it, but working groups are discussing this aspect. I do think that we have to use them in different settings, but always with confirmation of a positive result by CSF or PET testing, because we're not there yet. There's still so much that we need to do. So at this moment, you can't use them yet in your clinical trials, in care and trials as standalone biomarkers. We think that the immediate use or the earliest use will probably be in the memory clinics, where the blood biomarkers can be added to the other measures that are being done. And upon a positive effect, a person can be forwarded to a tertiary memory clinic where PET and CSF analysis can be performed to confirm the results. And that helps you in the diagnosis. But the patient journey starts earlier. Usually they start with the GP. And that's our hope. And it's a more distant use, but we really hope that we can have added value there, because that can reduce the burden of Alzheimer for our healthcare system, but it can also inform the patients much better if we can apply the blood biomarkers together with the cognitive test for a first screening, the first step in the diagnostic process, after which people can be referred to the memory clinic. So in summary, I hope that I give you an outline to convince you that the plasma or serum levels of p-tau 181, 217, 231, we have not yet defined or decided which is the best biomarker and do we need them all. Amyloid levels, GFAP and neurofilament light, they show changes in the early stages of AD and relate to cognitive decline. I've shown this cross-sectional analysis and also in the longitudinal analysis. They were predictive for longitudinal decline and conversion to dementia. And these biomarkers have the potential to improve trial design because they are low invasive tools and they can help to screen, but they can hopefully also be used as outcome measures. Remember the donanemab trial results showing decreases in p-tau. That's very promising. A lot of work needs to be done. Implementation has already started or studies to prepare that. So I think it's becoming a reality. The world with biomarkers for Alzheimer's disease are becoming a reality. And at last, I would like to thank the people of my team in the neurochemistry lab at Amsterdam UMC and also of the Alzheimer's Center and all our international collaborators. Thank you for your attention.
To this part of the symposium because you address all the biomarkers, so maybe we can put some of those questions up again. In the meantime, I would like to tell you that the extensive work that has been done, particularly in Europe, now here in the United States, we are becoming extremely interested in these biomarkers. And as you said, I think that a lot of work has to be done still within memory disorders clinics to try to correlate these, the findings on these biomarkers with other markers or biomarkers we have of brain pathology, including PET. So, a question from the audience was the GFAP and NFL measure with the SIMO assay or mass spectrometry.
That's a very simple question for me to answer. So indeed, it was done on SIMOA assays. And nowadays there is a 4-plex assay. It looks like that I'm advertising it, but that's very convenient because it's a multiplex assay in which you can measure also amyloid 42 and 40 and GFAP and NFL all at once. And the additional benefit of just using also the information that you get from NFL and GFAP, maybe some prognostic information, is that also if you make a combined analysis of these biomarkers, that it improves your diagnostic performance. So the very low diagnostic performance that was mentioned by Suzanne Schindler for the immunoassays, for discriminating AD from controls, you can improve it by this SIMOA assay. So you need a couple of more markers, but at the same time, it's more cost effective. And it's also an instrument that is more widely available. So there is some benefit in there.
Very good. Excellent. So we are going to then finish the morning session here. Thank you very much again for an outstanding presentation. And we'll reconvene at 1:30.
Perfect. Thank you.
Well, good afternoon, everyone, and welcome back to the afternoon session of the 11th Annual Nantz National Alzheimer's Center Symposium. The topics this afternoon will have to do with therapy. We have reviewed a number of wonderful biomarkers, new biomarkers in plasma that make much easier the evaluation of potential candidates for clinical trials, and also they will have tremendous usefulness in the clinic. But of course, this will only happen if we can do something about these diseases, if there are treatments that are effective and make a difference. So that's why this afternoon is dedicated to new treatments, and I'm delighted to introduce Dr. Randall Bateman. He's a professor of neurology at Washington University in St. Louis. And Dr. Bateman is also the director of the Dominantly Inherited Alzheimer Network and the DIAN Trials Unit. He was in a study that published a number of years ago. He showed us how the problem with amyloid buildup in the brain has to do with clearance. This was extremely interesting seminal work in a very difficult study, and he has continued to enlighten the neurological community in this field. So I'm delighted to have him speak about Ganturivan solunacimab in dominantly inherited Alzheimer's disease. Dr. Bateman.
Hello, I'm Randy Bateman. I'm going to be presenting today on the Dominantly Inherited Alzheimer's Network Trials Unit, trials of solanezumab and gantenerumab. Shown here are my disclosures that include the DIAN-2 Pharma Consortia, the funding for these trials from the National Institutes of Health and other organizations. Starting with what is Alzheimer's disease and how do we define it? It is the most common form of dementia. It's defined pathologically by the hallmark lesions of amyloid plaques and tau tangles in the brain, and is a specific diagnosis. Like other dementias, it is a neurodegenerative disorder causing damage to synapse and neurons, and that loss in Alzheimer's disease typically leads to an early memory impairment in early stages of the disease, and it progresses to involve other cognitive areas and eventually basic neurological function, including eating and breathing, that culminates in the death of the patient if they live long enough. Alzheimer's disease is age dependent, and it doubles every 5 years past the age of 60, and the cause of that age effect is not fully understood yet. We do know that some families that carry mutations in amyloid precursor protein or presenilin 1 or 2, the cause of Alzheimer's disease in those individuals is the mutations that alter amyloid beta production in the brain. However, for most other forms of Alzheimer's disease, we don't fully understand what causes it. We understand some of the risk factors, for example, apolipoprotein E4 and other risk factors, but the etiology of the disease still remains obscure in most of the late onset sporadic cases. Also, notably, Alzheimer's disease is a unique disease in people, and there's not a natural model that recapitulates the full progression of Alzheimer's disease. The pathology of Alzheimer's disease affects the brain, and one of the end stage effects of that is the neuron and synapse loss shown here. The hemisection on the left is shown with atrophy in the cortical region and the subcortical areas throughout the brain, and especially the hippocampus. Compared to a brain that does not have Alzheimer's disease, you can see the full cortex and subcortical regions. Microscopically, when this is evaluated in Alzheimer's disease, and is how we define it, the amyloid plaque shown here on the left and the tau tangle shown here on the right define the disease. When both of these are present in sufficient quantities in the setting of a clinical dementia, we call that Alzheimer's disease due to causing the dementia. However, through recent research, we in the field have been able to define the stages that the plaques and the tangles develop over and can identify Alzheimer's disease before clinical onset. And I'll review some of the evidence for that from the Dominantly Inherited Alzheimer's Network. You can see here the amyloid plaque has a good number of neurites, and these are filled with hyperphosphorylated tau coursing throughout this plaque, which is fairly large compared to the size of a nucleus in a neuron. And here, this neurofibrillary tangle is comprised predominantly of hyperphosphorylated tau in the microtubule binding region of tau. One of the first patients that was described by Dr. Alzheimer was Auguste Dieter. She was a young woman, relatively young, affected in her early 50s with a dementia that he described and characterized Alzheimer's disease very well. In a later study of more than 100 years later, her brain tissue was found to have a presenilin 1 mutation that is thought to have been the cause of her dementia. So the first patients being described due to Alzheimer's disease were in fact early onset cases, and in some of those caused by the mutations that today we know can cause early onset Alzheimer's disease. Now, people with this early onset form due to mutations are very rare. It accounts for about 0.1 to 0.2% of the total population of Alzheimer's disease. And the three genes that have been identified are amyloid precursor protein, presenilin 1, and presenilin 2. These genes all work together as the active enzymatic component of gamma secretase that cleaves APP to generate amyloid beta, and they all seem to have a common pathophysiology that they increase the production of amyloid beta, and especially longer forms such as amyloid beta 42. The comparison of these autosomal dominant forms of Alzheimer's disease with sporadic Alzheimer's disease is shown here. You can see that the clinical and the cognitive presentation are largely similar, starting with an amnestic phenotype and progressing to involve other cognitive areas before basic neurologic function is affected. The atrophy that we can measure in life by MRI is also seen in characteristic regions in the hippocampus and the whole brain cortex. The amyloid PET scans identify the deposition and aggregation of amyloid beta in the brain in the form of plaques and fibrillar amyloid beta. We find that in the cortex in early onset dominantly inherited Alzheimer's disease, just as we do in late onset, but there seems to be a predilection for deeper structures such as the basal ganglia also showing some deposition. There's hypometabolism in characteristic regions of the brain and the parieto-occipital areas. And the biochemical changes that we detect in CSF can now be detected in plasma. And this includes lower amyloid beta 42 and the 42 to 40 ratio, increases in soluble levels of N-terminal tau, as well as phosphorylated tau species. And as I reviewed, the pathology is the same as we define the disease by amyloid plaques and tangles. What's interesting is that in early onset autosomal dominant Alzheimer's disease, about 50% of people can have Lewy bodies in the amygdala or the cortex. That's similar to what we find in sporadic AD, but in sporadic AD, we also find many other pathologies, some of which we think are possibly age-related. The Dominantly Inherited Alzheimer's Network was established in 2008 to bring together medical and research centers that follow people with these mutations to better understand how the disease begins and how it progresses over time. The Dominantly Inherited Alzheimer's Network, or DIAN, has enrolled more than 600 participants in its study, and we follow these people longitudinally over time to determine the rate and the order of change. Shown here is a map of the DIAN centers and the associated DIAN trials unit, which I'll describe more in detail later, in the centers throughout North America, Central and South America, Europe, and Asia and Australia. One of the earliest findings from DIAN was that there is a characteristic age of onset of clinical symptoms of Alzheimer's disease in these mutation carriers that is based on when their parent had their symptom onset, and more accurately based on when their family or other people with the same mutation have their onset. And so you can see the range here is from around 30 years old upwards of 60 years old and beyond for the typical age of onset of these mutations, and that these are individual ages of onset that you can see largely will occur within about plus or minus 5 years of the predicted age of onset. We can use these estimates to tell us about the estimated years to symptom onset in individuals, and stage people where they're at in the progress of the illness, whether they're pre-symptomatic, 1 year, 5 years, 10, or 20 years before their symptom onset. And so, for example, if the average age of onset is 45 and someone was 35, they would have an estimated years of symptom onset of minus 10 years, 10 years before the expected symptoms would begin. By identifying where people are at in the course of their Alzheimer's disease stage, we can estimate what biological changes occur in the brain at any point in life or their study. And so we utilize this estimated age of onset here, shown now at 20 years before. And you can see the amyloid plaques beginning to deposit throughout the cortex, subcortical regions, including the caudate and basal ganglia, and here in the precuneus. As this amyloid deposition progresses and we reach about 7 years before symptom onset, significant amounts of hypometabolism set in, and then we have atrophy set in about 3 to 5 years before symptom onset. I'll let this play through one more time, just so you can see again the characteristic change that occurs over time in the brain, year by year as it goes through. As the amyloid plaques build up in the brain, really beginning 15 to 20 years before the first symptom onset begins, it continues to progress rapidly over those years until it reaches a near maximal amount right at symptom onset, right at 0. And then there's not more substantial amyloid deposition, but these other changes have already started, including hypometabolism and atrophy. Subsequent to that study, tau PET scans enabled us to track the aggregated tau pathology in the brain and follow that over time. What you can see here is the estimated years to symptom onset at 0, and this is about 10 and 20 years before symptom onset, that the tau PET, unlike the amyloid PET, really only changes right at symptom onset. So the amyloid plaques might begin back here, but if one doesn't have a mutation, there's no tau PET accumulation. If one is asymptomatic with a mutation, is defined by a clinical dementia rating of 0 or no dementia, you can see that the tau PET is largely normal, with perhaps one exception. But if someone is already symptomatic, CDR greater than 0, shown by the red squares, you can see that they all have elevated and highly elevated amounts of tau PET, again with one exception. And that's shown here in a specific region. The precuneus tau is one of the earliest spots where we detect tau deposition. And you can see here that these changes really are quite remarkable and almost binary for the presence of clinical dementia. And so as we put this together in a map that shows the years, you can see 2 decades before the amyloid plaques are building up and growing before they plateau out. Hypometabolism and atrophy set in later years, and especially in the symptomatic period. And the tau PET really begins right at symptom onset. And so we can define these by stages: symptomatic, secondary prevention trials would target this stage where you would have pathology, but not yet symptoms of Alzheimer's disease. And primary prevention would target before there are pathological changes in the brain. We can also describe these as by the pathological stage of tangle predominant growth, amyloid plaque growth, and pre-pathology. So as we think about disease modification, there are 3 large domains that the field has always considered. And we're still answering these, but some of these we are gaining information and answers for Alzheimer's disease. For example, which target should we target for Alzheimer's disease is a key one. And for several decades, the focus has been on amyloid and amyloid beta species. Now, many trials are focusing on ways to target tau, and we'll discuss why that's important and how tau interacts with the disease course. But not all targets can be safe to target for maximal effect, and they may be good targets from a biological standpoint, except for the safety problems. And one example of this is general gamma secretase inhibitors that had negative safety effects beyond their amyloid beta lowering effects. Another issue that has challenged our field, and I think in other fields too, is what if the target is correct, but it's not enough? What if the impact, the pharmacodynamic impact of the particular drug and dose and duration that's being used is insufficient? It's too little. And most Alzheimer's disease trials have had this issue. Most drugs don't substantially hit their target and change the effect. So there have been dozens, hundreds of failed trials, and most of these have not been able to demonstrate that they have a consistent normalization of their target, that they affect their target in a major way. That's changed in the last few years for some drugs that target amyloid plaques, in that the PET scans are demonstrating large removals of amyloid plaques to normal levels, and we'll talk more about that. Also, when is the right stage to treat? I showed that the amyloid plaques really accumulate 15 to 20 years before, and they reach maximal levels at symptom onset. So it's trying to remove plaques years after they've been fully deposited and reached maximal levels. Is that really the best strategy, or should we go earlier into secondary or even primary prevention trials? So this is just a brief summary of some of the development in our field that has led to where we're at today in terms of prevention trials. And I just want to recall that the first proteins were described in the 1980s. In the 1990s, genetic causes of Alzheimer's disease, including the mutations that I described, were reported. And in the 2000s is when we really first began developing drugs to target amyloid beta. And more evidence came out that lowering amyloid beta in this natural experiment of mutation in APP can protect strongly against Alzheimer's and dementia. And the first prevention trial we launched in 2012 for Alzheimer's disease by targeting amyloid beta with several different drugs, and I'll review that. Prevention trials have continued to gain momentum and are now used in sporadic Alzheimer's disease. Several trials are ongoing. And oral beta secretase inhibitors were launched, but then stopped due to safety side effects. And so where we're at today is where you have amyloid prevention trials, tau prevention trials, combination of amyloid and tau prevention trials. And we're moving even earlier from secondary prevention to primary prevention. So in order to do this, we need many partners across the world, including those who develop drugs. Those are the pharmaceutical companies shown here by the Diane-2 Pharma Consortium. Patient advocacy groups such as the Alzheimer's Association have been key stakeholders and partners in this. And the National Institutes of Health, through the NIA, has strongly supported these trials in mutation carriers through the Diane-2. In our first goal of trying to target the amyloid pathology, we sought to bring in 3 classes of drugs. One is a monoclonal antibody that targets amyloid plaques. Another is a monoclonal antibody that targets soluble amyloid beta. And a third are the secretase inhibitors or modulators that lower the production of soluble amyloid beta species. In the trial that we launched in 2012, our plan was to enroll approximately 210 people to be randomized to one of 2 drugs, a soluble antibody that targets plaques and a soluble antibody that targets soluble amyloid beta, and have a placebo group, a pooled placebo group to compare it to, in addition to the observational data that we had collected. Non-carriers were also included in the trial because most people did not know their mutation status, and many did not want to know. And so we ran this trial with them being blinded and assigned a placebo. We transitioned from a 2-year biomarker trial to a 4-year common close design of a cognitive endpoint study. And this accelerated our ability to have those measures over a longer time period. Our primary and secondary outcomes are shown here. We changed from the primary outcome was the biomarker outcomes, a change in amyloid PET by PIP-PET, and a change of CSF, a total A-beta 42 for solanezumab, to having the primary be a newly developed multivariate cognitive endpoint to try to capture the change across the range of clinical stages, as well as capture very subtle cognitive change in the asymptomatic period. We developed a novel statistical model to analyze this, borrowing data from the observational study where people had been followed for a number of years. We also assessed secondary clinical outcomes and also biomarker outcomes. The trial launched and enrolled and completed successfully. We completed 100% of our enrollment goals with an 18% screen fail rate and a 7% dropout rate per year. 73% of people who started the study finished the study with an average duration of 5.2 years. Of those in the study, we had a 99% completion rate of all our cognitive measures, clinical measures, the multiple PET scans and MRIs, cerebrospinal fluid collection by lumbar puncture, and blood collection. Shown here is for each arm is the number of people over time that stayed in that arm. 100% and 80% are shown here. The groups were very well balanced. We used a minimization algorithm to account for the various factors given the limited size of our trial to ensure that the different groups would be approximately well balanced. You can see that across the main domains and the variables of interest, that each of the groups were well balanced, including the n equals 69 that we borrowed from the Diane observational study. In terms of dosing, we started with the doses at the time that were thought to be efficacious for both gantenerumab and solanezumab. However, external data from our trial indicated that this dose would not be sufficient, and we needed to increase the dose. So we went from 225 milligrams to 1,200 milligrams in the middle of this trial. And you can see these plots for each individual and how the dosing occurred. Similarly, with solanezumab, we ended up deciding that we should increase the dose from 400 milligrams to 1,600 milligrams here later in the trial. An important point is that with the common closed design, people continued to be treated in their originally assigned groups, active treatment or placebo, even after they reached the 4-year biomarker last visit. And so we continued cognitive and clinical measures, but we did not have any biomarker data at these higher doses beyond this time period. Shown here is the cognitive composite and its components. You can see that our cognitive composite for asymptomatic people shown in these dashed lines is normal at 0. This is a z-score of this composite. And remarkably, the groups did not decline over the 4 years of this double-blind randomized period. In contrast, the symptomatic individuals who started the study started with impairment. You can see here -2 on this composite, and did decline over the duration of the trial. When we looked at each of the individual components, it was clear that on some of these, there may have been some small amounts of decline, but otherwise were largely stable or even improved a little bit during the trial in all groups, including the placebo group, while the symptomatic individuals did decline in various measures. On our clinical measures, you can see again that people who started with a baseline CDR0 largely stayed close to that for the full duration of the trial, regardless of the arm they were in, while the symptomatic people continued to progress clinically in the CDR sum of boxes and the functional assessment scale shown here. So based on these clinical and cognitive findings, we were not able to conclude any effects on the decline because our placebo group and the asymptomatic group did not decline, and the symptomatic individuals had largely progressed by the time we began using the higher doses. So as much as we could say is that at lower doses, we don't think there was a substantial effect on clinical or cognitive effects on the trial. The biomarkers tell a different story. They're much more informative than our cognitive and clinical measures were during the double-blind period. And what we found was that gantenerumab, the antibody that removes amyloid plaques out of the brain, did have a substantial effect not just on its target in removing a substantial amount of those amyloid plaques, but on multiple downstream measures of removing plaques, including the soluble amyloid beta 42, the soluble N-terminal tau, and the phospho-tau 181 species all had significant improvements, and the neurodegenerative marker NFL also had slowed worsening. In contrast, solanezumab did not show these effects and did hit its target substantially, but moved in the wrong direction on NFL. So looking closer at the gantenerumab results, you can see here an asymptomatic CDR0 participant with substantial amounts of amyloid plaques had these removed to a large degree by the year 4. The people who had a CDR greater than 0, started symptomatic, began with higher amounts of amyloid plaques, and by the time they had finished the study, even though large amounts were removed, they had not gone back to normal, and so they hadn't reached full amyloid plaque removal. In terms of the soluble biomarkers, we saw improvements in amyloid beta 42 to 40 by about 40% of the way towards normal. Total tau and p-tau 181 moved about 30% towards normal, while NFL had about 40% in terms of slowing the natural increase that occurs as the disease progresses. So that was our first trial. It concluded in 2019. We have an ongoing extension of an open label extension of gantenerumab, and I'll talk more about that in the context of what our next prevention trials are aiming to do. DIAN-2 has launched a tau-directed platform called the Next Generation Trial Platform, and we're focusing on tau for multiple reasons and doing things differently based on the lessons we learned from the first trials. One is that we are breaking up the population to study each separately. So instead of combining symptomatic and asymptomatic people in the same cognitive study and model, we're separating these out into groups. So symptomatic people could be up to 10 years after symptom onset. The secondary prevention will tighten up the population to use people 10 years before up to symptom onset. And the newly launched primary prevention trial will go even earlier, targeting people who are 25 years to 10 years before symptom onset, before they have any substantial amyloid plaque development. For the tau drugs, we will be looking to incorporate different classes of drugs as well as different targets into this tau platform. So why target tau? The past 5 to 10 years of pathological studies in Alzheimer's disease have clearly demonstrated, similar to what we showed in DIAN in sporadic Alzheimer's disease, there's an amyloid phase that builds up, and then there's this tau phase. And the tau phase is much more tightly correlated with clinical presentation, cognitive manifestations, and progression. And so many of us see this as the effector arm of the pathologies in Alzheimer's disease. And if we're going to have a significant impact at the symptomatic stage, to really change the course and have a chance to stop that disease progression, many of us think we need to target tau in addition to other targets, including amyloid. And so that leads us to the concept that for Alzheimer's disease, we might be looking at combination therapy, targeting amyloid plaques and tau tangles at the same time in the same people, may have the best chance to slow or stop the progression of the disease. That design is shown here. We have a combination trial design, and this is just launched at the end of 2021, where we are enrolling people who are either symptomatic or pre-symptomatic, and they'll be treated differently. So the symptomatic individuals who are CDR greater than 0 will first be treated for 6 months with an anti-amyloid drug, in this case lecanemab, before being randomized to the anti-tau drug, in this case E2814, or its placebo. In contrast, asymptomatic individuals who are CDR 0 will be randomized at the entry of the study to the tau drug or its placebo for 1 full year before then receiving anti-amyloid drugs to remove the amyloid plaques. For primary prevention, this is now launching in early 2022. And the rationale perhaps is the strongest for this kind of trial from a scientific standpoint. We internally call this the ultimate trial or the ultimate test of the amyloid hypothesis. which is if you prevent amyloid plaques from ever forming, can you actually prevent all the downstream consequences of Alzheimer's disease and completely prevent Alzheimer's from coming on in this population? And now that the DIAN-2 has been built and many centers are supporting it, this is now feasible. This trial is led by Eric McDade, who has worked over the past several years to bring researchers from all over the world together to design this critically important trial. There's strong support from participants, families, and researchers, and as well as regulators that we've been working with in the design of this trial. So shown here is a timeline and an outline of the various drugs that have been launched in the platform. I've described the solanezumab and gantenerumab results, and that we've transitioned to this exploratory open label extension. And we're now using even higher doses in these individuals to try to completely remove all amyloid plaques and see what the biological effects are for downstream biomarkers, but also to track what happens to cognition and progression and clinical status. We had launched a beta secretase inhibitor that was stopped early due to safety signals. And so that was stopped, and that was our third amyloid drug. And we're now launching the 3 tau drugs. I described the combination trial of an anti-tau E2814 that targets the microtubule binding domain of tau, as well as lecanemab, which targets amyloid beta oligomers and plaques and removes those out of the brain. This will be a large trial with a 2-year biomarker endpoint and a 4-year cognitive endpoint. We're currently evaluating other drugs to launch in the tau next-gen drug arms 5 and 6. And those designs are to be determined. They may include an anti-amyloid drug in combination, or they may be tau monotherapies, depending on the drug. And then I also described the primary prevention trial, and that will be launching imminently in early this year. And that's supported by a large number of philanthropic and public funds, as is the tau next-gen trial. So with that, I'd like to end by recounting a historical precedent for the ability to really target an aggressive genetic disease and have a massive impact in health. Shown here is the posterior aspect of a young Japanese woman's ankles, and you can see the cholesterol deposits here in the skin. She had a mutation that her family carried that causes heart attacks and strokes in their 30s, 40s, and 50s, and typically would lead to premature death by the 50s. She was treated with a drug called Compactin, which was one of the first statins. And after a few months of treatment, you can see what was perhaps the first biomarker of statins when lowering cholesterol was the resorption of these cholesterol deposits in the skin. This class of drugs and other cholesterol lowering agents would go on to lead to decades of healthy life for individuals and families with this mutation. And so by a similar vein, we think that it's possible to learn a great deal from a genetically inherited form of the disease, go in, target very specifically and powerfully that defect, and have a large impact on the medical outcomes. And that can then translate over to the general population in terms of prevention strategies. So with that, I'll end in giving thanks especially to our research participants and family members, the many researchers around the world that make this possible. Shown here is the Dominantly Inherited Alzheimer's Network and the individuals that lead those centers. On this slide are the DIAN Trials Unit members that help support and run the study. And on this slide are the DIAN-2 sites that help run the current studies and the prior studies that I presented. Thank you.
Dr. Bateman, and I have a question for you regarding the primary prevention trial. Obviously, these patients have mutations that are related to increased amyloid production. So I assume that in some way that the trial will be looking at reducing amyloid. But are there any markers in this population about inflammation, peripheral inflammation, and of course, inflammation in the brain perhaps has not been studied, but could this be another venue to approach the very, very early stages of the disease? Inflammation treatment.
So you're correct in that there hasn't been extensive studies in the inflammatory component of autosomal dominant Alzheimer's disease. However, we do have some markers. One of those is soluble TREM2 as a marker of microglial activity and finding its receptor. And so that's been studied in DIAN. And what's been found is that the soluble TREM2 levels really begin to substantially increase about 5 to 10 years before symptom onset. And a few people, we can see some subtle changes before then in terms of rates of change, but it really seems to be after amyloid plaques begin to grow and are being established. We do see it as a downstream reaction, and the potential for targeting it for treatment is of very high interest as it is for sporadic Alzheimer's disease. Many of us think that the inflammatory component that changes as the disease progresses is a key part of what's leading to the end damage to the neurons in the brain. And so if there's a way to modulate that or block that damage, we think there could be the potential for real effects in terms of slowing or stopping neurodegeneration.
Thank you very much. I wonder whether we have any questions from the audience or online. Doesn't seem to be any. Your presentation was super clear and very informative. It's an exciting cohort you have. We have a number of families here and are very grateful for what you are doing. So thanks very much, Dr. Bateman. Really appreciate your participation. So we are going to move on with the second presentation this afternoon, which is on 3 different immunotherapies for amyloid, aducanumab, donanemab, and lecanemab. And the topic is going to be discussed by Dr. Stephen Soloway, who, in addition to being a good friend, is the director of the Neurology and Memory Aging Program at Butler Hospital in Providence, Rhode Island. He is the Martin Zucker Professor of Psychiatry and Human Behavior and Professor of Neurology at the Warren Alpert Medical School of Brown University, also in Providence. So, Steve, thank you very much for participating in this symposium today.
Well, thanks so much, Joe. Can you hear me okay?
Yes, we can hear you very well.
And can you see my slides too? Just
yes.
To make sure we're all hooked up. Okay, terrific. Well, thanks so much for inviting me. I wish I could be there in person to deliver this talk and discuss it with all of you. It's a very lively topic. It's gotten a lot of attention. So I'm going to be focusing on the anti-amyloid monoclonal antibodies that are in development for sporadic Alzheimer's disease. I know you've heard from Randy about what's going on in the DIAN program. I feel very fortunate to have been part of that program from the very beginning, and Randy and the WashU team have just done a fantastic job. We work with many entities to improve the diagnosis and treatment of Alzheimer's. Of note for today's talk is that I've worked with companies that are developing antibodies targeting amyloid, with companies also developing PET tracers and other biomarkers to help with clinical trials and with drug development. I don't stand to benefit from any drug financially from any drug under development, but I want you to know about my relationships. I was the co-chair of the investigative steering committee for the aducanumab phase 3 program, and I've also had a lead role in many other antibody programs. Since Joe invited me to speak at the Nantz Symposium the last time, which was in 2015, there have been a lot of advances in the fight against Alzheimer's disease. We now have a national plan with increased NIH funding, dramatic increase in funding, really. Wonderful observational cohorts, ADNI, Diane, LEADS, BioFinder, NAC, ABLE, around the world that really are helping us make advances and diagnose and treat Alzheimer's earlier. We have PET tracers that can safely detect the plaques and the tangles of Alzheimer's. We have drugs that lower amyloid and seek to modify tau. Because of these advances, we've now opened the era of Alzheimer's prevention. I'm sure you've heard about some of that from Randy. We have promising plasma biomarkers to improve the diagnosis of Alzheimer's and encouraging gene-modifying treatments to slow progression. So it's a very dynamic field. Among these advances are the advances in molecular brain imaging. So now there are 3 tracers that are FDA approved to see the amyloid plaques. We know that they build up early, well before memory loss. And Randy and the Diane team have put together a lovely template about the changes in the brain, at least what we know so far, in the biology of Alzheimer's disease, gained in large part from the Diane program from families with autosomal dominant Alzheimer's disease. And so we know that the amyloid plaques build up early, followed by changes in tau, and then later changes in MRI, FDG, and even later in tau, PET, and in clinical decline. And these are really exciting advances. We're almost, at least from a research point of view, ready to take them for granted, but they're really yet to come into clinical practice, where looking at the spread of tau pathology in patients that are amyloid positive, we can see that it typically follows a Brock staging that we've seen from neuropathology. And as a result of these advances, we can now do molecular phenotyping. And we hope to soon be able to introduce this into clinical practice, where a patient who has concern about memory loss or even risk of memory loss can have a staging of their amyloid and tau pathology, and hopefully other pathologies as we have better biomarkers, to see where they are on the AD spectrum and to make a more accurate and early diagnosis, and also to target the pathology that individual, to personalize their care. Therapeutically, we've had limited options, as you all know, if you're working in this area. We have cholinesterase inhibitors and a weak NMDA antagonist approved for the dementia stage of Alzheimer's disease. They offer some benefit, but patients typically progress, become disabled, unfortunately, and die most of the time from Alzheimer's disease, with late-stage Alzheimer's disease. But as a result of these advances, we don't have to wait for dementia before intervening. And previously we did, at least in the early days of Alzheimer therapeutic trials. Patients had mild to moderate or even more advanced dementia that were enrolled in trials. Now we're targeting people with early Alzheimer's disease, with mild cognitive impairment or mild dementia, or even those that are at risk for developing Alzheimer's disease but are still cognitively normal. And our goal really is to modify the disease course, to diagnose early, intervene early, and try to slow the process down. There's been a lot of focus on amyloid pathology. We were very hopeful about beta secretase inhibitors as being an oral agent, could be economical and widely available to prevent the buildup of amyloid plaques. So far, we've had trouble in clinical development with side effects with beta secretase inhibitors. Where there's been the most traction is on plaque-targeting antibodies that are a passive form of immunotherapy, monoclonal antibodies that target neuritic plaque of various kinds and help lower the plaque buildup. And this really grew out of the initial work from Dale Schenk and others with active immunization, showing in transgenic mice, if you target A-beta with an active vaccine, you can substantially lower amyloid pathology. And the first two trials in the early stage of monoclonal antibody development against A beta, one was bapineuzumab, and this was a trial in mild to moderate dementia, 78 weeks in duration. And we discovered that the main side effect from these plaque targeting antibodies is something called ARIA, or amyloid-related imaging abnormalities, which requires MRI safety monitoring. ApoE4 carriers have a higher rate of ARIA, and so were initially dosed at a lower rate with bapineuzumab than non-carriers of ApoE4. We did not yet have amyloid imaging routinely available, so patients were not required to have a positive amyloid test to enter the study, but we did have a sub-study with PIB, with an early tracer, and with CSF. And that study did not show a clinical benefit, but there was evidence of biomarker changes on amyloid PET and CSF. We had to limit the dose because of ARIA. And so this is one of the first examples of ARIA. You can see on the FLAIR image here, a patient prior to treatment in the upper left. This is an E4 homozygote who developed these prominent areas of high signal in the right hemisphere. The medicine was held. This was after just a single dose. And over the next 10 weeks, the edema, the ARIA-E, resolved, and they were able to go back on a lower dose of the medicine. So this person was asymptomatic, even though the imaging change was quite prominent. And because of this, this was a new finding, and we were more conservative in limiting the dose. And dose seems to matter for treatment with anti-amyloid antibodies. The two components of ARIA or ARIA-E are edema, or ARIA-H, and hemorrhage, which shows up as microhemorrhage or as areas of superficial siderosis. Clearly, cerebral amyloid angiopathy is a main risk factor for developing ARIA. And we limited patients with demonstrable MRI changes consistent with CAA in the clinical trials. So what did we learn from bapineuzumab? Well, one is we learned that approximately 20% of participants weren't building up amyloid. Even though they were diagnosed in experienced centers, they had an amnestic syndrome that resembled Alzheimer's disease, but probably many did not have Alzheimer's disease. And as a result, we now do amyloid testing, especially if the therapeutic target is amyloid lowering. We were limited, at least in that initial study, by the rate of symptomatic ARIA as a predefined rule. There was no clinical benefit at the doses that were tested, and that could have been due to the stage of the disease or the low dose that was tested, but there were some biomarker effects. One of the next antibodies to move forward, which you've heard a lot about at this point, is aducanumab. This is actually a human antibody that gets into the brain at low doses. It binds to neuritic plaque. It stimulates microglia to help break up the plaque. And in a phase 1b trial called PRIME, there were encouraging results. There was dose-related amyloid lowering, and for the first time, we saw a slowing down of clinical decline at higher doses. Now, the study was not powered for clinical efficacy, but this was an encouraging result that at least we were moving in the right direction. This is an example of someone, a patient on our site, who had a good, in my experience, we've had now 67 patients on long-term treatment with aducanumab through the phase 1 and phase 3, and now 26 patients on open treatment since approval, so almost 100 patients. So a lot of clinical experience with this drug. And there are responders or apparent responders and non-responders. And this is an example of someone who did well, 78-year-old with mild cognitive impairment. and on high dose of aducanumab for 5 years, open label, and really didn't decline very much. And the family and he and the family were very noticed it, very appreciative, and our clinical team also noticed it as well. And we thought, wow, this is a good outcome. And we had a number of patients like this. And he only began to decline after the medication was discontinued. We also had patients who didn't appear to respond, who had a normal progression of Alzheimer's disease where there was no evidence that there was a benefit. So 2 phase 3 trials of aducanumab for early Alzheimer's. So now we're targeting people with mild cognitive impairment or mild dementia who are amyloid positive. In this case, it was on an amyloid PET scan. And the main outcome was the CDR was a composite measure of clinical and cognitive assessments, the CDR, Clinical Dementia Rating Scale, some of the boxes. And initially, we started out with lower high doses for the ApoE4 carriers because of concerns of ARIA. The target dose for non-carriers was 10 milligrams per kilogram, and the target dose for the non-carriers was 6 milligrams for the carriers was 6 milligrams per kilogram. We did a titration study along the way in carriers, and we found that it appeared to be safe to take carriers to 10 milligrams per kilogram. So the dose was increased for carriers halfway through the trial, and some of them got that higher dose and some did. We used MRI safety monitoring to detect ARIA and had stopping rules and suspension rules. And we also looked at downstream biomarkers. Now, as I'm sure almost all of you have heard, this phase 3 program was fully enrolled at over 3,000 participants, a global study. And 1 year prior to completion of the trial, after 50% had received the high dose, a futility analysis was done and the study was stopped because there was concern when the 2 studies were pooled that they would not reach the primary outcome. A very jarring event. All of the remaining data was then analyzed. Even though the data set was incomplete, there was a substantial amount of data. And it looked like one of the trials met the primary and secondary outcomes clinically and the other did not. And there were also some positive effects on downstream biomarkers. And this is actually some new data from Biogen that was presented at CTAD about 6 weeks ago that shows that with treatment in both trials, there was substantial lowering of plasma phospho-tau. And so a biomarker, which is great because it's so easily available in the blood, which tended to, this lowering or the change in p-tau correlated with change in amyloid load and plaque clearance, and also with a modest degree with evidence of clinical benefit. So suggesting that plasma p-tau could be a marker of therapeutic response or of progression, which would be very helpful to have both in clinical care and in clinical trials. But more work needs to be done with this biomarker. The main safety concern was ARIA. It was typically transient and manageable in the trial setting. The main risk factors were the dose of the medicine and ApoE4 carrier number. 75% of cases were asymptomatic. 88% were of mild to moderate radiologic severity. The symptoms tend to be, when they do occur, tend to be nonspecific: headache, dizziness, unsteadiness, confusion, and visual disturbance. But more serious cases can occur, which resemble the inflammatory-related syndrome of CAA. So there aren't many of them, but there have been recent reports with open-label treatment of a number of serious cases, and they're important to know about so we can, A, know how to manage them and also figure out how to decrease the chance of that occurrence. As I mentioned, ApoE4 carrier status is an important risk factor. Patients who are non-carriers have about 20% rate of ARIA. Patients who are heterozygotes, about a 40% rate. And patients who are homozygous free for about 66%. So there's quite a big difference depending on the ApoE genotype. We strongly recommend that ApoE testing be done for all patients being considered for treatment with aducanumab. And that's to help inform patients and families about the risks in order to weigh risks and benefits, and also to guide safety management for the clinician. This is what ARIA typically looks like. You need FLAIR sequences to look for the edema. Here's an area, a consolidated area of edema here in the right posterior hemisphere. Here's a more subtle area of sulcal increased signal on FLAIR. Here's a really subtle area. These are easy to miss, of just a little bit of a sulcal effusion here. You have to look very carefully for those. And then these are areas on the heme-based sequence, on gradient echo here, of microhemorrhage, and that's called ARIA-H. These are the most common appearance of ARIA-E and ARIA-H. But I mentioned it can be severe in rare cases, and this is an example of such a case. This patient happens to be a neurologist who wrote a book about his experience, and he's an ApoE4 homozygote who was on the placebo arm in the phase 3 program, but then went on open label treatment. And after 4 doses, after the second dose of 3 milligrams per kilogram, he developed explosive headache, fluctuating confusion, and alexia. And you can see he had prominent areas of multifocal areas of edema here, areas of microhemorrhage on the gradient echo scan. And he was stabilized and initially was sent home, but his symptoms worsened, and he was readmitted and found to have some epileptiform activity. Seizures can be associated with more severe ARIA, and which was treated with levetiracetam. He received high doses of methylprednisolone with an oral taper, and you can see he had a good outcome, that the ARIA-E resolved over time. I think the methylprednisolone helped accelerate that. We only have empiric evidence of this from treatment of CAARI, but we recommend it for cases like this that are quite symptomatic and severe radiographically. And he had a good cognitive outcome. He's functioning, I happen to know him personally, he's functioning very well, and he actually improved on his cognitive testing to a slight degree. So this was a severe and serious case, but with a good outcome. There have been cases that haven't had as good an outcome, and that's why it's very important to be prepared for a case like this if you're going to initiate treatment with aducanumab. Another anti-amyloid monoclonal antibody is donanemab, being developed by Lilly. This is a humanized IgG1 directed at the N-terminal pyroglutamate on established plaques. The phase 2 program had 272 individuals with MCI or mild dementia. This study had a couple of innovations. One, they required a moderate amount of tau uptake on a fluortaucipir tau PET scan. I think the thinking was that patients with a moderate degree of tau would be most likely to respond to an anti-amyloid treatment, that perhaps more severe tau buildup suggested more severe disease in the brain and less responsiveness to an amyloid-targeted treatment. And very mild tau may not have as much of a clinical benefit. They also had a stopping rule that if the amyloid, when the amyloid level came down below the cutoff for Alzheimer's disease on the PET scan, then the medicine was held. That was not true of aducanumab. And they showed substantial dose-related amyloid lowering and some slowing on cognitive decline on a composite measure of cognition and activities of daily living. They also had a fair amount of ARIA, which was related to ApoE4 carrier status. And these were encouraging results, and now a phase 3 trial in early Alzheimer's is fully enrolled, and we look forward to those results in the next year or so. Here's some of the data from that trial, from the phase 2 trial of donanemab, showing the substantial amyloid lowering, the evidence of clinical benefit. They also demonstrated a lowering of plasma p-tau. In this case, the isomer was p-tau 217. So there was a lowering of plasma p-tau. And so encouraging results. Lecanemab is another anti-amyloid antibody. It's an IgG1 monoclonal antibody that targets soluble forms of aggregated A-beta, oligomers, protofibrils, and insoluble fibrils. This study had 854 participants with early AD. It was a dose-finding study, and they found, using a Bayesian design, that 10 milligrams per kilogram every other week was the most effective dose. They ran into a safety issue with a couple of cases in Europe, and they had to stop recruitment of ApoE4 carriers who had received less than 6 months of treatment at the high dose. So the exposure to high dose was limited in carriers in the second half of the trial. They also showed a significant dose-dependent lowering of amyloid on the PET scan, with some evidence of disease slowing on clinical measures at 18 months. The rate of ARIA was lower than with other plaque-targeted antibodies, but the exposure could be an issue. We'll wait to see on the phase 3 trial, which again is fully enrolled and should read out in about a year. You've heard probably from Randy about gantenerumab, another plaque-targeting antibody. This is a fully human IgG1 monoclonal antibody targeting aggregated A-beta. One difference here is the medicine is administered subcutaneously. In the trials done so far in sporadic and autosomal dominant Alzheimer's disease, there are decreases in amyloid PET and lowering of CSF p-tau, but no evidence yet of clinical effect. The ARIA rate in DIAN was 19%. At higher doses with a higher rate for E4 carriers. And phase 3 trials at higher doses in early AD are fully enrolled. And, again, we look forward to that readout in the near future. And you probably saw this encouraging biomarker data from the DIAN trial with gantenerumab showing a lowering of A-beta and a lowering of CSF total tau and phospho-tau. So what are some of the key lessons from these 3 antibodies in sporadic AD, aducanumab, donanemab, and lecanemab? Each drug showed significant dose-dependent amyloid lowering with some evidence of a benefit on slowing of cognitive decline. However, the relationship between amyloid lowering and clinical benefit really requires further study. ARIA is the most common side effect. It's related to dose and E4 carrier number. Titration seems to lower the rate and severity, and safety monitoring with MRI is required. Baseline tau PET may help predict treatment response. We're encouraged by what we saw from donanemab, and plasma p-tau may help in selection and monitoring of patients, but again, we need more study here. So as a result of these data, the FDA accepted a new drug application for aducanumab. The clinical team at FDA felt the data were sufficient to warrant approval of aducanumab. However, the advisory panel took a different view, and they felt the data there were some encouraging aspects, but the data were insufficient and requiring further study. So after much debate, the FDA decided to grant accelerated approval for aducanumab for the treatment of Alzheimer's disease based on amyloid lowering as a surrogate biomarker likely to be associated with clinical benefit for disabling disease without a meaningful treatment and requiring an additional trial, a confirmatory trial with placebo. I think the feeling of the FDA was they wanted to take a forward-thinking position to make medicines like this that does target a core pathology of the disease. There is some evidence of clinical benefit. To make the medicine available to patients while further studies being conducted, and also to encourage investment and provide incentive for innovation and to accelerate drug development. The FDA amended their indication, which was quite broad initially. The initial indication was Alzheimer's disease, to conform with the focus of the trial on early Alzheimer's disease, MCI, and mild dementia. So the prescribing information is for early Alzheimer's disease. And they also gave the green light to donanemab and lecanemab to be considered for accelerated approval, and those submissions have begun. As a result of this approval, we have begun offering aducanumab through open treatment. And we're a little more conservative than the prescribing information and really align ourselves pretty well with the phase 3 trials. And I strongly encourage you to read the appropriate use recommendations that were put together by Jeff Cummings and a group of Alzheimer's experts. By way of disclosure, I'm one of the authors on that. But we tried to guide clinicians on how to safely, we don't take a position on whether or not you should be prescribing it, but if you do, here's how to do it. And we recommend following the label for only treating patients with mild cognitive impairment or mild dementia. Patients require amyloid testing, either with CSF or amyloid PET. The mini mental range for the phase 3 program was 24 to 30, and we follow that. We also exclude people with more than 4 microhemorrhages, any macro hemorrhage. We don't want patients with significant CAA or bad vascular disease, which would predispose them to a more serious adverse event. We require ApoE testing for all patients so they can make an informed decision and they can help us guide safety management. The medicine is titrated. It's 1 milligram per kilogram for 2 doses, given monthly, then 3 milligrams per kilogram for 2 doses, then 6 milligrams per kilogram for 2 doses, and then followed by 10 milligrams per kilogram. And there's a set schedule for MRI safety monitoring in order to detect ARIA early, and ARIA tends to occur early with treatment. We plan for a major rollout of this drug because it is a new treatment option for Alzheimer's disease, and it requires a very close collaboration with primary care where most patients with Alzheimer's disease are seen. Also collaboration with infusion centers and radiology for administering the medicine and for good detection of side effects. We put together an excellent treatment team, and I'd be happy to share our protocol with you for any centers that are interested, and also talk about the composition of our treatment team. We rely in large degree on a group of nurse practitioners who are terrific, help us do a lot of the screening and safety monitoring. We have a weekly treatment team meeting where we go over all cases who are being considered for aducanumab and also review any safety issues that have come up. There's been a lot of uncertainty about insurance coverage, so there's been a fair amount of time spent on talking with families about that. There is a patient access program that Biogen is providing, which can help cover the cost of the medicine. It's very, we didn't have a very diverse population in the phase 3 program. We think these type of treatments need to be studied broadly and also be made available to a diverse population of patients. Some of the main issues we've run into is making sure that people have early Alzheimer's disease. So often patients with more advanced stages of disease are requesting treatment, and we're trying to be pretty definite about that we really haven't tested it for late stages of Alzheimer's disease, and we have not been including them. We also look very carefully at the baseline MRI scan to make sure there's not evidence of more than 4 microhemorrhages, macrohemorrhage, or significant cerebrovascular disease, severe white matter disease. We got to be careful to screen for comorbidities, active epilepsy, an underlying inflammatory condition, autoimmune conditions. Patients on anticoagulation were not studied in the phase 3. There isn't a tendency for leakiness of blood products, and so we're not including patients on anticoagulation. We are including patients on antiplatelet agents, and primarily that's been aspirin. We don't know how long patients need to be treated. It makes sense to me that there could well be an induction phase where we lower amyloid below a certain level, and then a maintenance phase where the medicine wouldn't be required as often. But that really needs to be tested in a trial. Just to share with you a little bit of our early experience with ARIA post-approval. So far, we've had 4 cases of ARIA, and all patients were E4 carriers, 2 homozygotes, 2 heterozygotes, all had severe radiographic ARIA, and all were initially asymptomatic. 3 were detected on the first safety MRI scan, and we obtained that after the 4th dose or before the 5th dose. And the package insert calls for before the 7th dose. So these patients may have been dosed through severe ARIA if we had followed the current label. And 1 was detected after the 2nd safety MRI, which is after the 6th dose. 1 was associated with more than 10 new microhemorrhages. 1 was unfortunately associated with cerebellar metastatic disease. I think that's just an unfortunate temporal pairing of those 2. I don't think there's a direct relationship. And 1 lost the ability to play piano and spell. And it's obviously very concerning for the patient and family and for us, but those symptoms have resolved. So as a result of the growing clinical experience, we are updating the appropriate use recommendations, and which should be published soon, we hope. And we are now recommending 4 safety MRI scans in the first year. That goes along with the phase 3 trial before the 5th, 7th, 9th, and 12th doses, basically as we're titrating up on the drug and making sure there's no evidence of significant ARIA. If ARIA does occur, and if it's at all symptomatic, we recommend suspending the treatment, monitoring clinically and with MRI until it resolves or stabilizes, and then deciding whether or not the patient can go back on treatment. If it's asymptomatic and mild, we follow the phase 3 guidance that the patients can be treated through that, but you have to monitor again clinically and with MRI to make sure it's resolving. If it's a moderate to severe radiographically, then the medicine should be held with ongoing MRI and clinical monitoring until it resolves. We have stopping rules in the new guidance. For any macrohemorrhage, more than 2 areas of superficial siderosis, this is a sign of CAA and an increased risk of bleeding. More than 10 new microhemorrhages since starting treatment, more than 2 episodes of ARIA, and any severe symptoms of ARIA. Again, the goal is to limit a serious or severe or disabling or fatal outcome. If you're going to administer this treatment, it's important to have a safety plan in place in case a severe case of ARIA occurs that requires hospitalization. I'm just showing you our protocol here for that. Patients need to know where to go, what emergency room to go to, and then you hold the anti-amyloid treatment. In our case, we're going to contact the vascular neurologist, obtain a brain MRI as soon as we can to try to evaluate for ARIA, admit, again, at our site, admit to the stroke service. If appropriate, we'll initiate treatment with high doses of methylprednisolone, monitor for seizures with EEG and treat appropriately, transfer to a higher level of care in our neuro ICU if needed, and then continue anti-inflammatory treatment if needed, immunosuppressive treatment to accelerate the recovery. Now, you've probably heard of a lot of the debate on the front page of the USA Today about Medicare and their plans for a national coverage decision for aducanumab and for anti-amyloid antibodies. In January, CMS proposed to cover this class of drugs through a coverage with evidence development, limiting coverage to patients in CMS-approved randomized controlled trials, and those weren't really, no significant detail was provided there. These had to be conducted in hospital-based outpatient programs. There was a priority to include underrepresented populations. And this NCD would apply to future anti-amyloid antibodies, even those receiving full approval. And there was an open comment period that ended just last week with more than 19,000 comments, and CMS will announce their final decision in April. In my opinion, this is a overly restrictive, essentially a non-coverage decision, and providing very limited access to patients while further study is being done. I think a more balanced approach, what would make the most sense, because we do need more data about safety and efficacy, and we also need access, and we want to encourage innovation. So I think we could do the same thing, have a coverage with evidence development through a treatment registry with an open label, prospective, longitudinal design, where we collect information about patients, about safety and efficacy, but also provide access and oversight. And I hope that CMS will land more in that, come to that decision. So here are some of the highlights about the, I like to emphasize safety. I want to make sure if we're providing this medicine, we can do it safely for patients. It's important to focus on early Alzheimer's with amyloid confirmation, carefully evaluate the baseline MRI for safety, screen for conditions that could predispose to a more serious outcome, perform ApoE genotyping and share that with patients. This will involve a change in our clinical practice. Amyloid testing and ApoE testing are not a standard part of clinical care at this point, but in terms of this treatment program, they need to be. Follow the safety MRI schedule of 4 MRIs and the schedule that I mentioned. And then we tried to provide stopping rules to help guide safe care. The key really with this class of medicine, as the database and the evidence base grows, is really discussing the risks and the benefits and helping the patient and family weigh that. Is it right for them? Can they afford it? And helping them make the best decision that they can. Just in the last few moments, I'll mention, we know amyloid builds up early, so it makes sense to target amyloid in the preclinical stage before there's really any cognitive impairment. And we are testing lecanemab, and all the other antibodies that I talked to you about today are being tested for prevention. This is the first patient to receive lecanemab as part of the AHEAD study, a wonderful couple at our site. 63-year-old cognitively normal guy at the time was working full-time. Both parents had Alzheimer's. He knew that he was an E4 homozygote, and had elevated amyloid, so an increased risk of developing cognitive impairment. And he really wanted to make a difference, not only for himself, but for others, to try to have treatments that slow down the disease process. Another key element is the lifestyle intervention. There's a wonderful article in the Lancet 2 years ago showing that approximately 40% of risk for dementia is modifiable, largely through lifestyle intervention. to promote brain health, vigorous physical exercise, Mediterranean-type diets, stimulation, good heart health. And now the U.S. pointer study is underway, well underway, to test this in 2,000 people, this type of multimodal intervention for patients 60 to 79 who are at risk of developing memory loss to see if it can improve memory over a 2-year period. Really excited about plasma biomarkers. I want to give a big shout out to Randy, who has really helped develop amyloid, an amyloid plasma biomarker. There are really exciting phospho-tau plasma biomarkers. This is really going to help with detection and make it more economical and more available, more widely available. What we're looking for, there's a lot of debate about the treatments I discussed with you today. What we're looking for is treatments that really have a bigger clinical impact. This is looking at the antisense oligonucleotide for spinal muscular atrophy, which has had a big impact on that disease, that childhood disease. We're looking for a similar impact, and we're actually going to be testing an ASO, an antisense oligonucleotide targeting tau. And we're excited about that, and hopefully that's going to gain traction. So I think in the future Nantz conferences, we're going to be talking about combination treatment, where we have healthy lifestyle approaches to promote brain health. All of us need to do this. Those of us who are at higher risk of developing Alzheimer's and neurodegeneration need to do more, and we'll need to focus on the core pathologies that we're struggling with, that each of us have, that predispose us to have cognitive decline, and target those in combination. So I think we're at a turning point in the treatment of Alzheimer's. We are opening the modern era for diagnosis and treatment. I can tell you that Alzheimer's first case was very controversial. He got booed off the stage when he showed the plaques and the tangles in his first case. They said that couldn't be. We are going to be diagnosing earlier and more accurately. We're going to be targeting the core pathology, and hopefully we're going to be doing more molecular phenotyping as we do in cancer, and targeting those components of the illness. It's our responsibility to build on this initial breakthrough, or these breakthroughs, and like we've done with MS and cancer and HIV. First treatment for MS, modern treatment for MS, was beta seron, which was approved through accelerated approval pathway as well. And now there are more than 20 disease-modifying treatments for MS. There are more than 200 treatments for cancer that have gone through the accelerated approval pathway. And we need to do a much better job of testing these medicines in diverse populations and making them more widely available. So I'm happy to take questions, and I want to thank Joe again for putting this conference on and for inviting me. Thank you.
Thank you very much, Steve. Again, very encouraging, wonderful presentation. You know, a comment I have, or a question really, is it looks that the ARIA and other complications of aducanumab are related to the amount of amyloid in the brain. I mean, we see it more in for homozygotes and so on. The problem is that these folks do not necessarily have very, very early AD. I mean, they may, or they may be relatively advanced. The amount of amyloid doesn't correlate with the cognitive status, as we know. It can be high before even the patient is symptomatic. So targeting the very early group, which I think is a very good idea, to look at people who have an MMSE of 24 or higher, that is not necessarily going to screen out folks with a lot of amyloid in their brain. So I applaud the new guidelines that you are putting together, and Do you think that having amyloid imaging rather than just CSF may help there to find those who have more amyloid in the brain?
Right. Well, I think we're targeting patients with amyloid in the brain, so that's one of the requirements actually to be included for treatment. I think certainly amyloid PET gives you more information about the distribution and the severity of the buildup. You actually get a quantitative number, as you know. I think what's really the driver, one of the main drivers for ARIA is really amyloid in the vascular tree. And we need really better imaging of that, better markers of that. I think we can do, and I would love to have your input, Joe, over time about this. I think we can do a better job on MRI. We don't use the most sensitive measures for microhemorrhages or siderosis. We tend to use gradient echo rather than susceptibility weighted imaging. So I think there may be markers of CAA that could help predict who's at higher risk of developing a more serious reaction to these antibodies. And also there's some innate immune tendency in a small number of patients to have a more serious inflammatory reaction, and we need a marker for that. I don't think we've identified that biomarker. So it's not just amyloid amount, because all of them are going to be elevated. It's really amyloid in the vascular tree and some innate tendency toward an inflammatory response.
Great. Thank you very much. That really clarifies it nicely. All right. I don't think we have any other comments on the
I know it's not very controversial. Not very controversial. Hasn't gotten too much attention. This has been an amazing experience.
So,
all the attention and the controversy and.
Well, there are more than 8,000 comments on the CMS.
19,000, more than 19,000 on CMS.
Right. We'll see what happens.
Yeah, it's been
one more month. All right. So thank you very much, Steve, for a very helpful
Thanks for inviting me. I'm sorry I can't be there in person.
Okay. All right. So thank you. And we are going to move on with our afternoon break and reconvene at 3:15 here.
Take care.
So we are going to start the last part of the symposium, and we are going to center the next two talks on inflammation and inflammation therapies, specifically inflammation therapies by Dr. Alier Safaridar. But I wanted to speak about neuroinflammation because when one looks at the brain of a patient with Alzheimer's, it is not only tau tangles and amyloid plaques that one sees. One sees microglial activation, inflammation is very prominent. Astrocytes become reactive. So inflammation is a very characteristic feature of Alzheimer's disease and related disorders. And I'm going to refer to some of these related disorders as well. These are my disclosures. The only one that is really relevant is this one, because Eli Lilly makes PET biomarkers for both amyloid and tau. And I'm going to be referring to studies done with this biomarker. All right, so we understand inflammation in the brain, in neurodegenerative diseases, mostly through work in experimental animal models. They're extremely helpful. But what goes on in the human brain in these diseases is not necessarily exactly what happens in animal models. For instance, in this study that looked at the human brain and examined specifically changes in microglia, astrocytes, endothelial cells, and neurons, it became very clear that the changes were more similar to human accelerated aging than to changes that one sees in experimental animal models. So there is no question that experimental animal models are very useful, but it is extremely important to look at what goes on in the human brain. And of course, people have done that, and one of the proteins that has been used as an indicator of inflammation has been the 18 kilodalton translocator protein, TSPO, which is expressed by activated microglia, astrocytes, and endothelial cells. And this has been the most frequent target of inflammation imaging. Most of the data that I'm going to show you is about TSPO. How about in postmortem Alzheimer brain? There are studies showing increased TSPO signal in postmortem brain, like the one from Metaxas et al. But there are also at least a couple of negative studies. This is one of them, the one where you see the frontal cortex and cerebellum being sampled. And the overall cohort of Alzheimer's was not different from the control group, but you can tell that some individuals had more TSPO. The other thing that is quite remarkable in this slide is that if you look at the Y scale, the one that tells you the amount of TSPO, the value in frontal cortex is quite a bit higher than the value in cerebellum. Cerebellum is typically not affected in Alzheimer's. So what is this telling us? Well, perhaps that we are dealing with one of the problems in neuropathology, which is that very small parts of the brain are sampled. And it is possible that inflammation in some of these individuals was not involving the frontal cortex that was sampled. Second thing is that the evaluation is that in one stage only, so one doesn't see what goes on throughout the disease process. So that's why TSPO has become an important target in PET, in positron emission tomography, and there have been a number of markers. PK11195 was introduced as far back as 1986. There are many studies done with PK, but PK has a very, very small binding affinity for the tracer. You can see that it's less than 1. So second generation tracers were introduced in the mid-2000s, and the binding in these tracers is affected by a polymorphism in the TSPO gene. So there are folks who bind in the tracer very well, high binders. There is a middle level, and then there are low binders that cannot be studied with these tracers because the binding is just too small. This applies to PBR28, applies also to DPA, although DPA has a very high affinity, but also it has very high radiometabolites that complicate the evaluation of the PET studies. So most recently, we've been interested in and working with ER176. The affinity is several fold, the one with PK. And because of its high affinity, even the low binders can be imaged, so we don't have to genotype our subjects. We can study everybody and then correct the scans by the genotype, the binding genotype. So how about the findings in neurodegeneration? Well, there are some very positive aspects. For instance, Pascual from the McGill group showed that PBR28 binding, which is a TSPO tracer, correlates nicely with CSF TREM2. So the evidence, indirect, if you will, about the usefulness of this tracer. However, unlike amyloid or tau tracers, the single subject studies with TSPO, with some of the tracers that we had in the past, were very difficult to interpret because the signal was so small. But using volume of distribution images with an arterial input function, you will see how one can see the abnormal signal very clearly, even at a single subject level. So let me show you some images in Alzheimer's. For instance, this is a 67-year-old man. Well, he doesn't have Alzheimer's strictly. He has preclinical changes. So the amyloid PET is positive. This is a PIV study, very little white matter binding, so one can see very nicely the areas of increased amyloid in the brain, both in the frontal lobe and precuneus. And in that same person, the ER176 inflammation PET shows a very clear signal, which is in the same regions. By the way, this image and a number of others are courtesy of Dr. Belén Pascual, who works here with us. So what do we see with these tracers in the Alzheimer process? It seems, or it has been postulated, that the signal is increasing preclinical AD, as I show you. Then it decreases as mild cognitive impairment advances, and then increases again in early and advanced Alzheimer's. So sort of a bimodal pattern. And this is not something that is completely confirmed by all the studies, still a postulate. And it is derived from a longitudinal study of mild cognitive impairment, where 8 mild cognitive impaired patients were followed by 14 months, and TSPO binding decreased on follow-up. So they postulated this peak, and as the patients were followed, the binding was decreased, and then it was increased again. Now, while TSPO PET is uniformly positive in AD in most studies, it may be negative in mild cognitive impairment. So there are a number of reports of positive TSPO PET in mild cognitive impairment. Some reports have been negative. You can see here how in this patient we see inflammation abnormalities in the frontal lobe corresponding to amyloid deposition. And also we see changes in the lateral parietal and precuneus corresponding to both the tau scan and the amyloid scan. Notice that the signal is not there in the entire brain. So again, if a neuropathologist were to look at this patient's brain at this time, then there could be a number of areas, including in the frontal lobe, where there is no signal. In other patients with mild cognitive impairment, the study can be negative, like in this patient. There is another intriguing study where, again, in a small sample, patients with MCI and Alzheimer's were studied repeatedly, and those who had higher inflammation at baseline had a slower progression. So this group here with higher inflammation progress more slowly than the ones with low inflammation, suggesting perhaps a protective effect of inflammation at the early MCI or middle MCI stage. Certainly, the TSPO signal correlates with the clinical phenotype nicely. This study from Chuck Kreisel showing posterior cortical atrophy, an AD parent. This is an inflammation PET. This is the more classic amnesic AD, which we saw. Well, by the way, and the images look very similar. These are different patients. This is a man with a CDR of 1, that is mild Alzheimer's, amnestic MCI. Amnestic AD, and you can see the amyloid deposition, tau, and the inflammation scan. Another individual, a woman with amnestic AD. In this case, the PIV study shows very nicely the amyloid. And in the same regions there is inflammation, which, by the way, this is a CDR3, so quite an advanced patient, and you can see how there is very little TSPO expression in the frontal lobe, but very pronounced in the parietal regions, again pointing to the sampling problem with neuropathology. Unless you sample many, many regions, you're bound to miss some of this inflammation that is present in the brain of these patients. When you look at a group comparison, the areas that are involved in inflammation are similar to the ones that we see affected by amyloid and tau, and precuneus is a favorite one, lateral and medial temporal regions, frontal lobe as well. How about the correlation between inflammation and amyloid in humans? Well, in the early studies, no correlation was found, but then more recent studies have found positive or complex correlations in some studies. For instance, this one published this past year in Neurology, there was a correlation only in amyloid negative, not amyloid positive individuals. These were very early patients. But this is a wonderful paper from, again, the McGill group, and they found a correlation between inflammation and amyloid. With tau, there are even fewer papers, but finding correlations as well. Now, some have postulated that inflammation correlates better with amyloid at the MCI stage and with tau at the AD stage. In our experience, the correlation between inflammation and amyloid and tau tends to be quite similar in both stages. We probably need to study more people with mild cognitive impairment. But both in MCI and in AD, we find that there is a strong correlation between inflammation and tau. So MCI, you can see this patient that I showed you actually before. This is the inflammation PET with frontal deposition on the left hemisphere. And there is correlation also with tau. Let me explain this graph a little bit. So what we are looking at here are individuals with mild cognitive impairment. This is an example of 4. These are different regions, and you can see the correlation between amyloid on the left and tau in the x-axis at the top row. In the middle row, we have the correlation between inflammation and amyloid. And in the lower one, there is the correlation between inflammation and tau. Now, looking at the average across 10 mild cognitive impairment subjects, there was a nice correlation, as you would expect, between tau and amyloid, a correlation between inflammation and amyloid, but the highest correlation was actually between inflammation and tau. This is a spatial correlation. What parts of the brain have both one tracer and the other? Something similar occurs in Alzheimer's, as you saw before in this patient. Amyloid scanned here with uptake particularly in the parietal lobe, frontal lobe, but also in the inflammation study, one can see the uptake in parietal regions. And in this other patient, also with Alzheimer's, again, there is a correlation between the inflammation signal and particularly well with the tau signal. So we found then that brain inflammation correlates better with tau in AD than with amyloid. And in this group, the correlation was better than between amyloid and tau. So what seems to be telling us is that inflammation is an extremely important process in Alzheimer's and certainly a likely target for treatments. Let me spend a few minutes discussing neuroinflammation imaging in frontotemporal dementia, very characteristic, and for this work I appreciate Dr. Belén Pascual, having done a lot of this work and allowed me to use this material to present it to you. So in frontotemporal dementia, the uptake, unlike in Alzheimer's, that involves the resting network, the default network, which is very widespread in the brain, parietal, frontal, and so on. In frontotemporal dementia, the process is much more focal. And for this reason, the study of these patients is very interesting in terms of inflammation, and I'll show you why. We typically divide the clinical phenotypes into a behavioral variant that presents with frontal lobe behaviors, disinhibition, loss of social nuances, and so on. Another group has non-fluent primary progressive aphasia. And finally, another group has semantic progressive aphasia. I'm not going to discuss another large group, the motor group, the corticobasal group, but we've done quite a bit of work on that group, and imaging, again, with inflammation markers is very interesting as well there. This lady had a behavioral variant. She was in her early 50s, 50, and her amyloid PET was negative. The nice features of PET is that there is a new compound, an Avidya compound, that is also has a very clean signal in white matter, so you can see whether there is any signal anywhere else. But her tau scan was negative, as it happens to many of the behavioral variant patients. However, the inflammation PET was very abnormal, and you can see the signal in the frontal lobe and in the anterior temporal regions. This lady was being denied any type of disability because basically people didn't believe that she had a neurological disease, a problem. These patients tend to be diagnosed of anxiety or behavioral problems, and this test was actually, in her case, extremely useful to be able to document that this was a neurological disease. In non-fluent variant, as one would expect, the inflammation signal is in the premotor cortex of the left hemisphere, as you can see here. And we see also signal with fluortaucipir. We still are trying to understand where the signal is coming from. Some of these patients have tauopathies, but the signal in these cases is more in white matter than in cortex, as I will show you in another patient. So we are not sure as to what this represents, but the inflammation signal is very, very clear, and is in the appropriate areas. Particularly interesting was a study that Dr. Pascual did in semantic variant PPA. These are patients who have a progressive difficulty with naming and then with understanding what people tell them. It's a semantic aphasia. It has a very low prevalence. It's very difficult to find these patients, fortunately for them, or for those who don't have the problem. For them, it's a problem because to do clinical trials, we need to have people coming from all over the country, and this is exactly what we do. But then you need to characterize them well so that we study samples that are uniform and are likely to be helped by a particular therapy. Now, the phenotype, as I said, is very characteristic. They have difficulties with single word comprehension and word retrieval. They have anomia. Articulation is very good. They can repeat. Syntax is fine. You listen to them, and they seem to be speaking fine. Most often is associated with TDP-43. This is not a tauopathy. It is associated with TDP-43. And it affects first the tip of the left temporal pole. So if you do cortical thickness measurements with MRI, what you see is decreased cortical thickness in the left hemisphere, and it tends to be greatest right at the tip of the temporal lobe. From there, the atrophy moves backwards as the time goes by. We've done some longitudinal studies, and this is exactly what one sees, and begins to spread to other regions, particularly the contralateral hemisphere. By the time most people with semantic aphasia or semantic dementia present to us, they already have some involvement of the right hemisphere. And then it moves into orbitofrontal cortex and also into insula. So very characteristic process. I wanted to show you the single case because, again, illustrates very nicely not only how well you can see inflammation with these traces, but also how the topography of involvement is critical to understand the neurobiology of the processes that we are looking at. And in this patient, a lady who was in her 50s again, you can see on the top inflammation imaging. This is tau, quote unquote, because this is not likely to be a tauopathy. It's a TDP-43 disorder in most people. But with fluortaucipir, with this tracer that we use for tau, uniformly we see an uptake in the tip of the temporal lobe, in the region that is most affected by the atrophy. You see how this is very highly regional, affects a little bit the contralateral side, which is involved in these patients as well. And there is no question that this reflects some type of neurobiological change, but we are still unsure about what it is this is. If you look at the signal is mostly in the white matter, or all in the white matter. Now, in the white matter, we do not see tau tangles, we see some TDP-43, but much less than we see in the cortex. So even the neurites that contain TDP-43 in these patients tend to be cortical. So this signal is something else. And you can see here how it is. You look at the cortex, for instance. This is the superior temporal sulcus. There is no signal there, but in the white matter, immediately in the core of the middle temporal gyrus, there is this signal that one can see with fluortaucipir. The situation with inflammation is completely different. The signal is cortical, as you can tell. The white matter is much less involved. And this is particularly well seen in the sagittal image, where one can follow the cortex nicely with signal from inflammation. The white matter is paler than the cortex, exactly the opposite to what you see here. And the inflammation is not just at the tip, is in these regions as well, at the back of where the process is going. So when one does group analysis, patients greater signal than controls. These are all family-wise error-corrected data for multiple comparisons. So atrophy, you saw it before, affects particularly the tip of the temporal lobe, but then extends posteriorly. We see some in the insula as well. With fluortaucipir, you can see a signal in the core. So the core is mostly affected in the images that we see with MRI and with fluortaucipir. However, inflammation, which is, by the way, present in all these regions, but the peak of inflammation is in the periphery of the areas that are affected. So this is remarkable. This is a very, very interesting finding, because it suggests that in the region where the sick brain is in the margin between sick brain and healthy brain, where the action is where inflammation is greatest. And this is a little bit reminiscent of what happens with the brush fire, right? The fire began here, likely the neurodegeneration began there, but then as the fire moves peripherally to involve, in this case, grass that was not involved, the flames are greatest at the margin. And this is what we see here. We see inflammation at the margin. And look at the nice correlation or correspondence between the greatest inflammation and the greatest spreading in the inferior and middle temporal gyri rather than in the superior temporal gyrus. And again, remember that this is tau, this is MRI, these are techniques that are completely different. Another important issue, which was made plain this morning, is to correlate what happens in the brain with what happens in the blood. And we are very fortunate here at Houston Methodist to work with the lab of Dr. Stanley Appel, whom you met this morning. He introduced the entire symposium. Dr. Appel has been working on inflammation in neurodegeneration for several decades now. He was the person who emphasized the importance of inflammation in neurodegeneration. And Dr. Faridar and others in Dr. Appel's lab are looking at the correlation between blood changes in different cell groups, of course, inflammatory cells, inflammatory cytokines, and so on, and brain changes. So we are doing TSPO imaging, and and looking at the correlation with peripheral inflammation. I told you that TSPO is perhaps not the ideal marker for inflammation because it is present in several cell types, doesn't have a lot of cellular specificity, although there is no question that it tells us where the action is in terms of inflammation in the brain. Dr. Fujita, Professor Fujita, who is the director of our PET core, was actually the person who characterized several of the inflammation traces that we've been discussing, PBR28, ER176, and he's now looking at targets beyond TSPO. TSPO is present in both protective microglia, we call it M2, and toxic, neurotoxic microglia, M1. These are not, different looking microglia. These are stages in the way microglia behave, but it is it would be very helpful to know what is the proportion of protective versus toxic microglia to evaluate treatment trials and also to enroll patients that are appropriate for a particular therapy at any given time. So he's looking at purine receptors. P2Y12 is expressed in the protective microglia, whereas P2X7 is present in the neurotoxic microglia. There is a tracer already for P2X7. The Leuven group has done some work already with actually with ALS, and very interesting work. They were able to actually find more signal with TSPO tracers than with this new tracer for purine receptors, but this is a nascent field, and I'm sure that there will be a lot of developments going on, and there is very active work in this field. Another interesting tracer is, or another interesting, tracer and target, 18F SMBT1 images astrogliosis, images the MAO-B receptor, which is very abundant in astrocytes, and in collaboration with Professor Okamura and Dr. Harada from the Tohoku University School of Medicine, Dr. Fujita is working on a study to determine the specificity of this tracer and its ability to image astrocytosis in these patients. It is displaceable by selegiline, so you can see pretty well whether there is a specific binding. This is an image that was lent to us by Dr. Willeman. You can see a healthy control image with this tracer and somebody with AD. Particularly nice is the binding in the precuneus. So to conclude, inflammation imaging is beginning to show patterns in the progress of dementia, but more work is needed. We still use TSPO despite its limited cell and state specificity because it tells us how much inflammation there is and where it is in the brain. And it may be very helpful to tell us about the neuroprotective effect of some of the therapies. And of course, we are working on additional imaging targets with greater state and cell specificity. And without any further ado, to thank the entire team and our collaborators. Thank you very much. Okay, any questions, comments late in the day? Anyone awake? Okay, so I'm going to then introduce Dr. Alireza Faridar. Dr. Faridar has published innovative data on the T-cell a particular group of T cells that are regulators of inflammation in the brain. These findings, I think, are very not only innovative, but really set the basis for new treatment approaches, and he's working on them. All right. Okay, so, well, let me address this question very quickly. The question is, what is your thought about the potential application of inflammation PET on evaluating the response to treatment in Alzheimer's drug trials? I do think that it would be interesting to do this in a subset of patients. Inflammation imaging is expensive, but in a subset of patients to be able to understand what goes on with inflammation, I think this would be a useful adjuvant, because there is no question that inflammation is a major player in neurodegeneration. Okay, so not seeing any more questions, Dr. Faridar. Thank you very much, Alireza.
Okay, thank you very much for the kind introduction. I will be talking about targeting adaptive immune system in Alzheimer's disease. Alzheimer pathology initiates with abnormal deposition of amyloid plaque 20 to 30 years before symptom onset. That is followed by inflammation reaction, tau protein deposition, neuronal loss, and symptom onset. Over the last 10 years, there has been increasing evidences that shows that inflammation is not only a reaction to plaque or tangle, but also an independent risk factor for initiation and progression of the disease. For example, in recent US studies, over 300,000 individuals, 48 Alzheimer risk genes were discovered, and interestingly, 2/3 of these genes were exclusively or most highly expressed in microglia. In addition to this genetic evidence, neuropathologic data also supported the role of inflammation. Some individuals might remain cognitively intact despite having a substantial amount of plaque and tangles in brain. That is called resilient or mismatched brains. Researchers in Mass General and Mayo Clinic published an interesting study and looked over postmortem brain of Alzheimer dementia patients and non-demented resilient brains. The amount of plaque and tangles were comparable between these two groups. The only difference was inflammation reaction. In Alzheimer group, there were more reactive astrocytes and microglia, which means that there is no neuronal loss or cognitive impairment in the absence of inflammation reaction. That also support the role of inflammation as a key mediator here. Neuroimaging studies also evaluated microglial activation in Alzheimer, as Dr. Mastu discussed comprehensively. In a longitudinal study, microglial activation was evaluated at baseline and 14 months later in MCI patients with TSPO PET scan. At baseline, there was a 41% increase in microglial activation, but 14 months later, there was a progressive decline in microglial activation. In patients with more advanced Alzheimer's dementia, microglial activation was increased by 36%, and 14 months later, there were further increase in microglial activation. This data suggests the dual peak in microglial activation. At earlier stage of the disease, anti-inflammatory microglia might release neurotrophic factors and anti-inflammatory cytokines to protect neurons. These cells are initial responders to amyloid plaque and tau protein, and will shift toward pro-inflammatory cells. These cells will release pro-inflammatory cytokines and superoxide and initiate self-propagating cascade of synaptic dysfunction, neuronal loss, and might contribute in disease progression. Another important concept is blood-brain barriers. In contrast to healthy brains, there is dysregulation of tight junction and compromised blood-brain barriers in Alzheimer brains that permits the entry of circulating inflammatory cells into perivascular space and brain parenchyma. In vivo studies suggest that peripheral and central immune cells together contribute in neuroinflammation in Alzheimer pathology. Now I will talk briefly about the status of peripheral immune cells in Alzheimer's disease. A subset of adaptive immune system is regulatory T cells that express high level of immunomodulatory markers of FOXP3 and CD25s. These cells will suppress reactive, adaptive, and innate immune system. Compromised function of the regulatory T cells will shift the immune system toward pro-inflammatory status. In a series of studies that led by Dr. Beers and Dr. Henkel in Appel's lab, Treg immunomodulatory function was evaluated in neurodegenerative process of ALS. Suppressive function of Tregs on T responder proliferation in ALS patients was significantly compromised. In addition, there was a negative correlation between suppressive function of Tregs and burden of the disease, which means that patients at more severe stage of ALS had less Treg suppressive function. And interestingly, patients with lower Treg suppressive function had faster disease progression. What about Alzheimer? The impact of Tregs on Alzheimer pathology was evaluated in transgenic mice model of 3xTG. These mice received intraperitoneal injection of anti-CD25, that is called PC61, that effectively eliminated Tregs from the body. Elimination of Treg in Alzheimer mice model exacerbated cognitive impairment in these mice. They also evaluated amyloid plaque and reactive glial cells in the hippocampus. Elimination of Treg in Alzheimer mice exaggerated amyloid plaque deposition and enhanced reactive glial cells in the hippocampus. In another study, Alzheimer mice model received intraperitoneal injection of interleukin-2 or IL-2. IL-2 is well known for selectively expanding Treg in the body. IL-2 administration to Alzheimer mice increased number of Tregs in blood and brain up to 3-fold. The therapeutic impact of IL-2 induced Treg expansion on cognitive function were evaluated. The black bar and gray bar here is wild-type mice. The white bar is untreated Alzheimer mice, and the red bar is interleukin-2 treated mice. IL-2 induced Treg expansion rescued cognitive impairment in Alzheimer mice. So, in the next step, they evaluated synapse density. As you can see here, there is an overall decrease in synapse density in Alzheimer mice model. But IL-2 induced Treg expansion and restoration restored spine deficit in these mice. And finally, IL-2 induced Treg expansion decreased amyloid pathology in the hippocampus. So, early depletion of Tregs accelerates Alzheimer pathology, and amplification of these cells have neuroprotective effects and rescues Alzheimer pathology. Now, what's the status of Tregs in Alzheimer clinical setting? In our recent study, we evaluated the immunophenotype of Tregs in 3 groups of patients, including Alzheimer patients, mild cognitive impairment or MCI, and healthy control. Number or percentage of Tregs and FOXP3 expression on Treg population were comparable among these 3 groups, but CD25 MFI in Treg population was decreased in Alzheimer patients, which might suggest that Treg in Alzheimer might be less activated. In the next step, we evaluated immunosuppressive function of Tregs in Alzheimer patients. Treg suppressive function on T responder proliferation was comparable between mild cognitive impairment and healthy control, but there was a significant compromise in Treg suppressive function in Alzheimer individuals. This is important data as compromised Treg suppressive function is associated with shifting in immune system toward pro-inflammatory state. In another study that led by Dr. Tome and Dr. Apollino lab, peripheral monocytes were isolated from Alzheimer patient and healthy control, and inflammation transcriptome were analyzed. There was a remarkable increase in expression of inflammation-related genes in monocyte population of Alzheimer patients. So, in addition to compromised Treg suppressive function, there is upregulation of inflammatory-related genes in monocyte population in AD individuals. The third component of inflammation that we evaluated, systemic inflammation, was plasma inflammatory mediators. Using proximity extension assay, 45 different plasma inflammatory cytokines and chemokines were evaluated in 40 Alzheimer patients, 20 Parkinson, and 20 age-matched healthy control. 6 inflammatory plus serum inflammatory cytokines were elevated in Alzheimer individuals, including TNF-alpha and 2 of its superfamily members, interferon gamma, TGF-alpha, and interleukin-17C. In addition to these cytokines, inflammatory chemokines were also elevated in serum of AD patients, including CCL2, CCL3, and CCL4. These chemokines are well known for activation and migration of monocytes to the site of inflammation, which is brain in Alzheimer patients. CCL11 is also a well-studied chemokine that is involved in activation of microglia in the process of aging that was significantly elevated in Alzheimer individuals. So, in Alzheimer patients, there is a compromised Treg immunosuppressive function that is associated with upregulation of pro-inflammatory cytokine expressions in monocyte population and elevation of plasma inflammatory cytokine and chemokine, which might enhance neuroinflammation in AD individuals. So, how can we target this systemic inflammation in AD? For the first time in AD, we evaluated the feasibility of expanding dysfunctional Treg in the lab. In this regard, Tregs were isolated from patients and expanded and cultured in the lab in the presence of interleukin-2 and rapamycin. After 2 rounds of stimulation, number of Tregs increased by 54 times within 24 days. The purity of CD25 FOXP3 positive T cells, Tregs, in the culture was enhanced following ex vivo expansion that was associated with elevation of immunomodulatory marker expression on their cell surface, including PD-1 and CD73. We also evaluated immunosuppressive function of these Tregs. Suppressive function of Tregs on T responder proliferation and pro-inflammatory myeloid cells were increased following ex vivo expansion. So, it seems that this dysfunctional Tregs in AD is restorable. But the question is, what's the impact of these ex vivo expanded Tregs on Alzheimer pathology? To answer this question, we developed an immunocompromised Alzheimer mice model by backcrossing a well-established Alzheimer 5X FAD mice to RAC2 knockout mice. These mice lack B, T, and natural killer cells. These are key immune cells for xenogenic cell rejection. In other words, we will be able to inject human cells into these mice without rejection. Ex vivo expanded human Tregs were passively transfused into these mice. Following peripheral administration, these Tregs were detectable in the CNS of AD mice. In the first step, we evaluated the impact of these ex vivo expanded Tregs on amyloid beta pathology. We had 3 groups of mice, including immunocompetent 5X FAD mice, immunocompromised 5X FAD mice with lack of adaptive immune system, and Treg-treated mice. Lack of adaptive immune system increased overall amyloid beta pathology in the hippocampus, but Treg treatment reduced total number and average plaque size in the hippocampus. In the next step, we evaluated reactive microglial cells by staining for CD68. Lack of adaptive immune system increased total number of reactive glial cells within the hippocampus, but Treg treatment reduced total number and plaque-associated microglial cells. And finally, we evaluated inflammation transcriptome on extracted RNA from the hippocampus. In comparing immunocompetent 5X FAD to wild type, 73 inflammation-related genes were upregulated and only 4 were downregulated. These most upregulated genes were mainly related to complement activation and microglial markers. Lack of adaptive immune system further strengthened pathologic overexpression of these inflammation-related genes. Then we evaluated the impact of Treg treatment on these upregulated inflammation genes. In this heat map, the right column is Treg treated versus untreated AD mice. Treg treatment suppressed 91 out of 99 unupregulated inflammatory genes within the hippocampus. Enrichment analysis of modified genes following Treg administration was centered in suppression of complement activation markers, pro-inflammatory cytokines, particularly interferon gamma, microglial markers, and toll-like receptors. So this data suggests that more than one pathologic inflammatory pathway is targeted by Treg administration. So Treg are restorable therapeutic target and might have some alleviation effect on AD pathology. But the question is, how can we expand or restore Tregs in the clinical setting? One potential option is isolating Treg from patients, expanding them in GMP facility, and infusing the restored Treg back to patient, which is called ex vivo expansion strategy. In a study that led by Dr. Tanhoff and Dr. Polinol lab, this ex vivo expansion strategy was applied to ALS patients in a phase 1 feasibility trial. Infusion of Tregs was safe and well tolerated. In all 3 patients, the rate of disease progression were slowed during infusion of ex vivo expanded Tregs, and this treatment strategy has been advanced to phase 2 trial. Alternatively, we can restore and expand Tregs inside the body. That is called in vivo Treg expansion strategy by administering low-dose interleukin-2 to patients. We evaluated this second treatment strategy, in vivo Treg expansion, in a phase 1 feasibility trial in Alzheimer patients. In this regard, 8 patients at mild AD dementia were enrolled with average age of 70 and MMSE score of 19. The presence of amyloid pathology was confirmed with positive amyloid PET scan or ADCSF signature. Baseline immune status, including Treg immunophenotype and function, were assayed. Monthly 5-day cycle of low-dose interleukin-2 immunotherapy were administered to expand Tregs population for total 4 months. And we monitored Treg population changes in plasma inflammatory markers, and cognitive status. First of all, this treatment strategy was safe and well tolerated in all 8 patients. Number of Tregs was increased up to 2-folds after each IL-2 treatment cycle and returned to baseline before the next cycle. Similar to Treg number, CD25 expression on Treg population was also amplified following IL-2 administration. Number of other T-cell population like CD8, natural killer cells, or T effectors did not change through this trial, which suggests that this low-dose IL-2 treatment strategy selectively expand Treg population. We also evaluated suppressive function of Tregs. Treg suppressive function on T responder proliferation was progressively improved through IL-2 treatment phase and returned toward baseline after discontinuation of the therapy. In the next step, the impact of IL-2 immunotherapy on peripheral monocyte population were evaluated. Peripheral monocytes were isolated at baseline and through IL-2 treatment phase. Expression of pro-inflammatory cytokines, including interleukin-1 beta, TNF-alpha, and interleukin-6 were downregulated following IL-2 administration. Actually, the downregulation was kind of consistent through 4-month treatment trial. We also found a correlation between improvement in Treg suppressive function following IL-2 administration and downregulation of inflammation cytokine transcription in monocyte population, which shows the linkage between Treg suppressive function and function of monocyte population. Earlier in the study, we showed that myeloid activating chemokines and pro-inflammatory cytokines are increased in Alzheimer individuals. We evaluated these markers longitudinally in our enrolled patients. Myeloid activating chemokines of CCL2, CCL4, and CCL11 were attenuated after IL-2 administration, In addition, we also found a decrease in the level of pro-inflammatory cytokines of interleukin-15 and TNF-alpha after each IL-2 treatment cycle. So, low-dose IL-2 treatment will restore and expand dysfunctional Tregs in AD individuals that is associated with suppression of pro-inflammatory cytokine expressions in monocyte population and decrease the level of pro-inflammatory cytokines and chemokines in the plasma. We propose that modulation of systemic inflammation might reduce neuroinflammation in these individuals. In collaboration with Dr. Pascual and Dr. Masdu, we monitored microglial activation in one of enrolled patients by applying TSPO PET scan at baseline and after 4 months of IL-2 immunotherapy. As you can see here, IL-2 immunotherapy suppressed microglial activation in this individual. However, this data needs to be reproduced in a larger patient population. And finally, and most importantly, we evaluated cognitive function by a test called MMSE. Higher scores means that they are doing better, and lower scores means that they are doing worse. MMSE score was improved through IL-2 treatment phase and returned toward baseline after discontinuation of the therapy. We also evaluated cognitive status with 2 other tests called CDR Sum of Box and EDSCOG. In contrast to MMSE, lower CDR Sum of Box or EDSCOG means that patients is doing better, and higher score means that they are doing worse. IL-2 immunotherapy improved CDR Sum of Box in 4 patients and stabilized in 4 others. EDSCOG was stable through this treatment phase. In other words, there was no deterioration in EDSCOG from day 0 to day 120 and 168. We also found a correlation between enhancement in Treg suppressive function following IL-2 immunotherapy and improvement in MMSE scores. This is exciting data, but the interpretation of this data is limited as there is a small sample size in a short period of time with no placebo group. With the support of Alzheimer associations and Gates Foundation, we have advanced its treatment strategy to a phase 2A double-blinded placebo-controlled trial in 4D patients. We will evaluate this treatment safety and tolerability of this treatment strategy, and also the impact of this therapy on AD-CSF core biomarkers of amyloid, tau, and NFL, and of course the impact on reducing the cognitive decline. And this treatment is already initiated. So, in summary, Treg immunomodulatory function is compromised in Alzheimer's disease. Impairment in Treg population contributes in Alzheimer progression. Tregs are modifiable therapeutic target, and promising result of restoring dysfunctional Treg in the phase 1 feasibility study. And in this regard, this treatment strategy has been advanced to the phase 2A trial. Here is my last slide, and our team, Dr. Rapol is a longtime chair of Methodist Neurological Institute. He and his team initially developed the concept of Treg cell therapy in neurodegenerative disorder and has been mentoring me to develop this therapy in Alzheimer's disease. Dr. Masdu is a director of Nantz National Alzheimer Center. His particular interest is the role of inflammation in neurodegenerative process, and supported and mentored me to translate this trial, this treatment strategy into a clinical trial. And here is our team in molecular immunology lab and Nantz National Alzheimer Center. Thank you so much for your consideration, and I take questions.
Thank you very much, Dr. Foreigner, and if you can please address the questions online.
So the first question is, do you know the initial cause of dysregulation of Treg cells in Alzheimer's disease? Is the cause independent of what's going on in the brain? There are different possibilities. One is that if Treg lose its function in response to prolonged inflammatory status in the brain and also in the systemic inflammation, that Treg, in dealing with this inflammation to suppress that, and then it loses its function. Because, for example, in some animal mice model, if we evaluate the suppression, evaluate the function of this Treg at very early stage, we might see an increase in suppressive function of Treg to control systemic inflammation. But with disease progression, they will lose that. This is one possibility. The other possibility is that I think that there might be a pathology that is also going on in the brain, like mitochondrial dysfunction, that might affect the Treg function, and they lost their suppressive function. And the last possibility is some other factors, plasma factors like exosome. We know that the plasma exosome that contain tau, amyloid, or inflammatory markers have been increased in the process of Alzheimer even years before symptom onset. And there might be a possibility that those kind of particles like exosome contribute in Treg dysfunction in Alzheimer's disease. And the next question, what protective role does consistent, regular, strenuous exercise over decades plays in the development of Alzheimer's disease? So, I think as some longitudinal studies have shown that exercise might have a protective role. In general, taking care of Alzheimer risk factors from younger age might reduce the incidence of Alzheimer later in life, including vascular risk factor management and exercise. Next question, exciting finding with IL-2 antibody. Please comment on how interleukin-2 antibody may impact CNS inflammation in terms of how does it get into the CNS? What will be needed to affect the CNS? And is there a pharmacodynamic biomarker for its engagement? One thing that I don't think that IL-2 itself maybe has effect on microglial function in brain, but I think that the effect of IL-2 is mainly through peripheral or systemic inflammation modulation. We had some data that showed that peripheral myeloid cells is modified following IL-2-induced Treg expansion, and also myeloid activating chemokines that might migrate inflammatory monocytes to the brain is also suppressed following IL-2-induced Treg expansion. I think through this pathway, IL-2 affects central neuroinflammation in the brain and reduce neuroinflammation. And what side effects might you expect from stimulating Treg cell, and how might this side effect be treated? One potential side effect is immunosuppression. Patient with Alzheimer's disease might be prone to infectious disease, and one of my primary concerns was this kind of immunosuppression put patients at higher risk of infection. But hypothetically, it seems that IL-2-induced Treg expansion strategy is not kind of typical immunosuppression. Actually, it might restore immune system, and so far we have not been dealing with any infectious issue. The most prominent, most prevalent side effect that we saw was injection site reaction. That was some redness that was improved within a week. I think it was the last question. Okay, thank you very much and have a good day.